and we're going to follow the handout that Dick provided for you, and I'll try to throw in a few of my own pearls along the way. And I'm glad to hear that I won't get hammered by you guys on the evaluations. The goals of this talk are consistent with the goals of the whole course, and it's meant to provide a way to organize your study as you prepare for the board exam in a few weeks. Review the major topics. Again, focus on the board answers, not necessarily on the hot topics in orthopedic trauma. And we wanted to try to help you identify what we feel are the consistently tested facts. And all of us that participate in this faculty regularly review the OID and the Academy self-assessment exams and trying to pick up things that it seems the test makers want to ask about. And then, of course, the ultimate goal of this course is to help you successfully pass the Part 1 of the boards. Resuscitation, you're going to start with a sort of an overview of general trauma principles, ATLS principles, if you will, then move into the upper extremity, and then end up the talk here, we're talking about pelvic fractures. So we're going to kind of we started with in the pelvis yesterday, we're going to end in the pelvis later on this morning. Remember, with trauma resuscitation, the ABCs, very simply, the A stands, of course, for the airway maintenance and control, breathing and ventilation, then circulation with hemorrhage control, your disability evaluation, which is essentially focused and complete neurologic examination of the patient, and then preventing the patient from suffering from exposure. And then, of course, after that comes the orthopedic issues, splinting and reducing fractures or mobilizing fractures. Remember that some of the general principles of resuscitation, it's very important to maintain hemodynamic stability during the trauma resuscitation. And remember that if the patient loses 1,500 cc's or 30% of their blood volume, or they have to lose that much in order to present with hypotension. So if you have a patient that's hypotensive on initial trauma evaluation, then by definition that patient has sustained a significant blood loss. The parameters for adequate fluid resuscitation, you would want to maintain the mean arterial pressure greater than 60, keep the patient being tachycardic, the heart rate less than 100, maintain the urine output at as close as possible to 1 cc per kilogram per hour, or roughly 30 to 40 cc's per hour. And then you can also monitor the lactic acid levels. I've seen this question on test exams before, where one of the most sensitive ways to measure the adequacy of your resuscitation in a trauma patient is to look at the base deficit. The base deficit, of course, is an indirect, gives you an indirect review of the patient's lactic acid levels, or indirectly is correlated to the lactic acid levels. Of course, lactic acid is the end result of anaerobic metabolism, which is what you're trying to prevent with your adequate trauma resuscitation. The fluids that we use in resuscitation are listed here in terms of the crystalloid being the most available and easily accessible. It's also the least desirable. So as you go from crystalloid on down through O-negative blood, then type-specific blood, and finally to cross-match blood, we would like to give cross-match blood, of course, whenever possible. That's the fluid of choice. However, of course, it is the one that's least available acutely in your resuscitation. So you sort of go through this protocol, and as soon as you have cross-match blood available for the patient, you'd want to give that. At a very minimum, we want to try to give type-specific blood as soon as possible. The initial evaluation, ATLS protocol, which you all have participated in at some point in your careers, really calls for 3 radiographic examinations in all trauma patients, beginning with the AP X-ray of the chest. And what you're looking for with all these X-rays are significant, potentially life-threatening injuries. The AP chest, you're looking for mediastinal widening, which could herald an aortic transection or a dissection, pneumothoraces, which would require urgent, emergent treatment. On the lateral C-spine, you want to be able to visualize C7 on T1 to assure that there's no significant deficit. And then on the AP pelvis X-ray, of course, you're looking for a potentially life-threatening pelvic ring disruption. So you want to focus on the pelvic ring as well as the acetabulum and both proximal femurs. So you can really glean a lot of information about your patient from just these 3 radiographs. Open fractures, we've covered that pretty extensively yesterday. Remember that the most important determinant in outcome in open fractures, regardless of where the open fracture is in the body, is to perform an emergent and thorough debridement. And that's a question that frequently comes up on test exams. Then once we've done our soft tissue management, our debridement, then we consider the various techniques for fracture stabilization. And depending on the fracture, depending on the patient profile, multiple different factors come into place, the so-called personality of the fracture, if you will, to determine what's the most appropriate form of stabilization. And of course, IV antibiotics are important, staged irrigation and debridement of the soft tissue wounds if necessary until we have soft tissue coverage. The Castillo and Anderson classification scheme for open fractures, it's kind of hard for me to even present this to you because I really don't want you guys to get caught up in your careers on focusing on the size of the wound, because as many of you know, there are many more important variables that come into play when determining the severity of an open fracture other than simply the size of the laceration, but it's what's in the literature. It's important to review it. In the original Castillo article, grade 1 or type 1 wounds were defined as soft tissue lacerations less than a centimeter. Then the grade 2 were lacerations between 1 and 10 centimeters, and grade 3s were greater than 10 centimeters. The authors subsequently issued a couple years later a second article in which they subdivided type 3 injuries into A, B, and C. The A injuries, type 3As, are ones in which adequate soft tissue coverage is available, and that would include a skin graft. Type 3Bs are where you have extensive periosteal stripping of the wound or perhaps gross contamination, such as farmyard injuries. And then the type 3Cs are the easiest really to recognize, because those are the ones that have the asignificant vascular injury that requires repair or revascularization of the extremity. Antibiotics and open fractures. Most open fractures, including most type 3 fractures, can be treated with a first-generation cephalosporin alone. Typically, Ancef is what's used. You can add an aminoglycoside for severely open type 3 fractures, 3B fractures, for example. And then occasionally you'll see on test examinations there's some special circumstances mentioned where there's gross contamination of the wound, a farmyard injury, or bowel contamination of the wound. Those are the situations where you would want to potentially add penicillin, and this organism that you're trying to cover in those situations is Clostridia. And then you want to maintain the antibiotics until you have until you have adequate soft tissue coverage. Now, let's look at some pulmonary complications of multi-system trauma. The first one we're going to talk about is fat embolism syndrome, and this is something that is seen with, can be seen with isolated long bone fractures. The incidence is anywhere from 0.5 to 2%. It's much more common in the polytraumatized patient with multiple long bone fractures, as high as 10 to 15%. The clinical onset of fat embolism syndrome typically is 24 to 48 hours post-injury, which is important in differentiating it from other things that it can be confused with, such as pulmonary embolism, for example, which typically does not present that early in 24 to 48 hours. And fat embolism syndrome is an inflammatory response to embolized fat globules. So these, by virtue of the intramedullary canal being disrupted, it exposes these marrow fat components to the bloodstream. They embolize the bloodstream and create this syndrome of fat embolism. The treatment is both prevention. Well, how can we prevent it? Well, we know that we can prevent it by early stabilization of long bone fractures, as we talked about yesterday, and then also supportive management once the diagnosis is made. The diagnostic criteria for fat embolism syndrome, the three hallmarks of it, if you will, are hypoxemia, central nervous system depression. Typically in your questions you'll see that the patient is confused or irritated, and then petechial rash. Those are the three things that seem to be mentioned. There actually are four major criteria which you see listed here, the three I mentioned plus pulmonary edema, and then four minor criteria: tachycardia, pyrexia, retinal emboli, and thrombocytopenia. Additional things that can support the diagnosis include a PCO2 and a blood gas greater than 55, or significant acidosis with a pH less than 7.3, tachypnea, dyspnea, tachycardia, and anxiety. All those things can corroborate the diagnosis. Now, what about adult respiratory distress syndrome, or ARDS? ARDS is different from fat embolism syndrome, although fat embolism syndrome can lead to ARDS. ARDS is defined as refractory hypoxemia and diffuse infiltrative changes on chest X-ray, and it is caused by poor lung compliance and poor gas exchange at the cellular level. And of course, ARDS can be associated with very severe and dramatic complications in the polytraumatized patient, including late sepsis, multisystem organ failure, and mortality. Thromboembolic complications are very important in orthopedic traumatic injuries, deep venous thrombosis and pulmonary embolus. It can be prevented by early mobilization of the patient, early stabilization of long bone fractures, which will allow you to mobilize the patient early, and then as well the use of prophylactic measures such as mechanical devices, foot pumps, SCDs. You all are probably aware that there's never, in orthopedic trauma at least, there's never been any study that's demonstrated superior efficacy of one of those techniques over the other. Low molecular weight heparins have really been studied quite extensively in orthopedic trauma and certainly do help in patients that are going to, with multiple injuries that are going to be slow to mobilize, and particularly with patients with pelvic and acetabular fractures. And then certain patients may benefit from a vena cava filter. Now, compartment syndrome, we covered that pretty extensively yesterday. Again, the most important fact, or the most important thing to remember is that the clinician must maintain a high index of clinical suspicion for compartment syndrome in order to correctly make the diagnosis and not miss it. And that requires you to, based on your experience as well as your understanding of the injury that the patient sustained and the potential for development of compartment syndrome, to really do serial examinations of the patient to make sure that you identify it when it develops. You should have a low tolerance to do fasciotomies. If you suspect that the patient has compartment syndrome, you should probably err on the side of releasing the compartments to avoid missing it. The 5 Ps are listed here. Again, the 2 critical things that are mentioned are the critical clinical sign would be pain out of proportion. That's often difficult to assess clinically because, you know, different patients, of course, have different pain thresholds. But basically, it means that the patient is experiencing more pain than you would typically expect from the type of injury that you see. And then the critical clinical test, or the hallmark of clinical examination, would be pain with passive stretch of the extremity. And just remember that if you have an obtunded patient, a patient with severe closed head injury, a patient that's intubated in your ICU, or a patient that's intoxicated or under the effects of drugs when they come in, you cannot rely on these things. So you even have to have a higher index of suspicion in those patients, and you really want to closely monitor those patients and err on the side of performing fasciotomies if it's necessary. The diagnosis of compartment syndrome, you can measure directly the compartment pressure using a Stryker needle technique or some other sort of similar technique. And remember that the most sensitive indication for a compartment syndrome is the delta P, which is the difference between the compartment pressure and the diastolic blood pressure. This slide says the mean arterial pressure, but it's really the diastolic blood pressure, and that's what defines the perfusion pressure that extremity is seeing. And 30 millimeters is kind of the thing that you can hang your hat on. If a delta P is less than 30, the patient has a compartment syndrome. Also, if the absolute compartment pressure measurement is greater than 30, then you really have to be concerned about compartment syndrome in that patient. Now, we're going to talk a little bit about spinal cord injuries, and I think this might be covered a little bit more in depth in the talk that was given to you previously on spine, but I did want to go through some of the basic facts of spinal cord injury, and particularly the spinal cord syndromes, because those do seem to show up on tests. Remember that the neurologic level with a spinal cord injury is defined as the most caudal spinal level that has normal motor and sensory function bilaterally. So the motor and sensory function have to be intact on both sides of the body. Incomplete injuries, when the patient presents with spinal shock, they will have areflexia. And of course, when the patient is in spinal shock, it's impossible to determine the extent of the spinal cord injury, whether they have a complete or an incomplete injury. What you look for is the presence of sacral sparing, which would be voluntary or intact perianal sensation and voluntary anal sphincter contraction. And the bulbocavernosus reflex is very important. And that, of course, is when you pull on the Foley or on the penis or the clitoris, and the patient has anal contraction with that, with a gloved finger in the rectum, then that indicates by definition the end of spinal shock. And when the spinal shock is over, whatever neurologic deficit the patient has, that's what they have. They got what they got at that point. Now, spinal cord injuries, the methylprednisolone protocol, it's really amazing to me over the course of my relatively short career how our thinking has changed on this, and it is constantly being updated. But you should be aware of what the most recent recommendations are for use of methylprednisolone. The steroids have to be initiated within 8 hours, preferably within 3 hours, if at all possible. You load the patient with 30 milligrams per kilogram and then do an infusion of 5.4 milligrams per kilogram per hour over the next 23 hours if the patient was started less than 3 hours. If the patient had the steroid started within 3 to 8 hours, it's actually recommended now that you continue the infusion for 48 hours. There are some new combined drug protocols that are emerging, and we may be revisiting this issue in the future, but this is what the current NACIS recommendations are for methylprednisolone. Now, the cord syndromes, let's just cover those briefly. The central cord syndrome is the most common cord syndrome. It's usually seen in elderly patients that have extensive osteophytes anteriorly, perhaps degenerative disc disease, and it's seen following hyperextension injuries to the neck. The clinical presentation is sacral sparing, and you'll have motor loss preferentially in the upper extremity over the lower extremity, and preferentially in the proximal muscles rather than the distal muscles. In the distal part of the limb rather than the proximal limb. So you'll have more pronounced motor deficit in the hand than you will in the upper arms. And full functional recovery is actually quite rare. This is a very serious syndrome. The Brown-Séquard syndrome is hemitransection of the spinal cord, so you'll have ipsilateral loss of motor function and proprioception and contralateral loss of pain and temperature sensation. These typically have a good functional recovery. The classic mechanism for the Brown-Séquard syndrome is a penetrating type trauma to the spine, and most of these patients will ambulate. Anterior cord syndromes are usually the result of a flexion and compression mechanism. The lower extremities are affected more than the upper extremities, which is a contrast, of course, to the central cord syndrome that we've already covered. In these anterior cord syndromes, you'll have preserved proprioception, and you can have a variable loss of motor function and pain sensation. These have a poor prognosis. Then finally, the very rare posterior cord syndrome, which is where the motor function, pain, and light touch are preserved, but you lose proprioceptive function. I've never seen a patient with a posterior cord syndrome. Now, the brachial plexus injury, and I would probably the best thing that I could recommend to you guys as far as the brachial plexus is that when you first get your test books, when you take your exam, open up the front page and just sketch out your brachial plexus, because you're going to refer to it several times during the exam for sure. And this is a very simple schematic that I think came from Hoppenfeld, and it really will help you sort of organize your thinking about the brachial plexus. If you can just kind of commit that to memory and just sketch it out right at the beginning of the exam, I think it'll help you. And of course, it's red trunks drive cats nuts is the way I was taught to remember it. The trunks cross at the level of the clavicle. So with clavicle fractures, you have to worry about trunk injuries, and then you just have to commit this to memory as the only way to tell you to do it, to understand the derivation in terms of the nerve roots of the various peripheral nerves. Now, brachial plexus injury, something that's important to understand and clinically is very relevant, is whether the injury is preganglionic or postganglionic. This would be a representation of a preganglionic injury here. Of course, here's the vertebral body. These are the posterior elements. Here's the esophagus and the trachea, the paracervical muscles here, and then this is the dorsal root ganglion right here. So a preganglionic injury, by definition, occurs before the dorsal root ganglion. A postganglionic injury occurs after that. And you can kind of refer to this diagram as we go through. You really can make a differentiation between preganglionic and postganglionic lesions on the basis of your clinical exam. Both syndromes or both types of lesions will present with motor deficit. So both types will have a flail arm. With a preganglionic lesion, you can have a Horner syndrome because of the disruption of the sympathetic innervation. You can also have a wing scapula, and the rhomboids can be non-functional due to the very proximal exit of the dorsal scapular nerve and the long thoracic nerve from the brachial plexus. With a myelogram, you can see traumatic meningoceles with a preganglionic lesion, whereas you will not see those in postganglionic. And then really the most important clinical finding is the sensory disturbance. Both types of syndromes will have flail arm, will have motor disturbance, but the preganglionic will have intact sensation. And if I go back to the previous slide for a second, and that's again because with the preganglionic lesion, the dorsal root ganglia are still attached to the axons. So sensation will be intact in the preganglionic lesion, whereas in the postganglionic lesion, that's not the case, and the patient will have both motor and sensory disturbance. So that really is the critical clinical differentiation. And with the EMG, you can see a maintained innervation to the cervical paraspinals with a postganglionic lesion, but not with a preganglionic lesion. That can be another diagnostic test that can help you make that differentiation. Now, the treatment of brachial plexus injuries, the majority of these are fortunately managed best with closed observation. You really base your indications for exploration based on the clinical findings and the extent of the recovery. There are a few indications for acute primary exploration of the brachial plexus, and that would include sharp penetrating trauma, but not gunshot wounds. The gunshot wounds typically cause a more concussive effect to the brachial plexus, and the prognosis for recovery in those injuries is actually quite good. Open fractures around, or open injuries in the shoulder clavicular region, patients that have progressive neurologic deficit that could potentially have an expanding hematoma or some sort of vascular injury, those would be definite indications for exploration of the plexus. And remember that upper plexus injuries generally have a better functional outcome because that leads to preservation of hand function, and that's most important with the lower portion of, or most derivation comes from the lower portion of the plexus. The reconstructive priorities in patients with a brachial plexus injury, the number one thing that you want to try to restore is flexion of the elbow, and that's an important point to remember. Then the rest of them are listed in the order of priority: shoulder abduction, to position, be able to position the hand in space, if you will, then sensibility of the hand, then finally wrist extension, finger flexion, followed by wrist flexion, finger extension, and finally intrinsic function of the hand, which unfortunately rarely is obtainable in patients with severe plexus injuries. The reconstructive options include direct repair of the nerves, which is rarely possible, but if you have a patient that has an acute penetrating trauma, it may be possible to do a direct nerve repair. More typically, you're going to need to do a nerve graft. These are the various sources for graft you can use: a sural nerve, the ipsilateral cutaneous nerves, or an ipsilateral vascularized ulnar nerve, again, because we're not anticipating significant return of ulnar intrinsic function. Neurotization can also be performed, and you can use cranial nerve 11, intercostals, the phrenic nerve, or the contralateral C7. Then you can consider doing a free muscle transfer, such as a gracilis, to attempt to restore elbow flexion to the patient. All right, so we're done with the brachial plexus, and we're going to move on now to upper extremity fractures. And Dick has organized this talk, as you see, beginning sort of from proximal to distal, as we did with the lower extremities. We're going to start with the clavicle and then end at the distal radius. And then at the end of this, he's got sort of the top 10 facts that he wants you to remember in preparation for your board exam. So let's start with the clavicle fractures. Remember that the medial aspect of the clavicle is the last long bone to ossify, and that does not occur in most adult patients till the age of 18 to 20, and then the epiphysis doesn't close typically until age 23 to 25. So this is something that frequently comes up, and you rarely will see it clinically, but you'll see it often on standardized orthopedic examinations where differentiating between a fracture and an epiphyseal injury with medial clavicle injuries. And it's very important to distinguish sternoclavicular dislocations from physeal fractures, and we'll talk about that. The sternoclavicular joint is unusual in that it's a diarthrodial saddle joint, and it's incongruous. There's really only 50% contact between the medial end of the clavicle and the sternum, and of course it's a joint composed of fibrocartilage and not synovial cartilage. The stability of the sternoclavicular joint is dependent on multiple ligamentous structures. The anterior portion of the capsular ligament is the strongest, and that is the primary restraint to superior displacement of the medial clavicle. Then you have the very important costoclavicular ligaments, or the rhomboid ligaments, which are listed here, and these resist superior rotation or lateral displacement, as well as inferior rotation and medial displacement, depending on whether you're talking about the superior or inferior portions of the ligament. Then you have the intra-articular disc ligament, which is the check rein against medial displacement, and also the secondary restraint to superior displacement. So the story here is that there really are multiple ligamentous structures that are responsible for the stability of the sternoclavicular joint and are necessarily disrupted if that joint is dislocated. We define sternoclavicular dislocations based on the anatomic position of the medial end of the clavicle relative to the sternum, and that can be either an anterior dislocation, as is seen here, or a posterior dislocation, as is seen here, and those both have their own unique sort of clinical features. An anterior dislocation can be diagnosed with a history of trauma, with chest and shoulder pain. Frequently, you'll feel a palpable bump on clinical examination of the anterior aspect of the chest wall, and that the bump can be exacerbated by abducting and elevating the arm, and these patients, of course, will have acute pain and swelling. Posterior dislocations can present with either dyspnea or dysphagia, due to the fact that the medial end of the clavicle is now impinging on the mediastinal structures. They also can have paresthesias in the affected upper extremity due to the close correlation with the brachial plexus and vascular structures. The affected shoulder will be shortened and thrust forward. The patients will have limited shoulder range of motion. They often will get relief of pain if you turn their head toward the affected side. And again, they can have significant pulmonary complications related to this injury. It's very difficult to diagnose a sternoclavicular dislocation on a standard AP view, chest x-ray, for example. So the view that's recommended is the so-called serendipity view, which is diagrammatically illustrated here, and that's taken with a 40-degree cephalic tilt. And what you basically want to do, this is what it would look like on this view for a normal. You draw a line through the axis of the clavicle on the uninjured side. If the medial end of the clavicle projects anterior to that line, then you have an anterior dislocation. If it projects posterior to that line through the opposite clavicle, then you have, by definition, a posterior dislocation. Probably the diagnostic procedure of choice for identifying and classifying these injuries really is a CT scan of the chest, and that's the most sensitive way to pick up the diagnosis. You can identify not only the presence of dislocations, but also physeal fractures. You can identify other clavicle fractures, and it allows you to visualize the mediastinal structures. Here's a good example of a posterior dislocation, and you can see how the medial end of the clavicle can really impinge significantly on the mediastinal structures. Anterior dislocations should be treated with a general anesthetic, abduction and extension of the arm, and direct pressure over the medial clavicle to effect posterior displacement of the medial end of the clavicle and reduce the sternoclavicular joint. Posterior dislocations are also managed with abduction and extension under anesthesia. You want to, oftentimes it's very difficult to get the medial clavicle back in proper alignment, so you may need to manipulate it either with your fingers or sometimes with a towel clip to grab the end of the clavicle and pull it back anteriorly into its reduced position. And because of the very close proximity of this the medial end of the clavicle to the vascular structures, it's recommended that you have a thoracic surgeon on standby and that you go ahead and prep the neck to the umbilicus so that you're prepared for a vascular emergency that may ensue with your reduction maneuver. It's kind of a dicey thing. Anterior dislocations, if the reduction is stable, you can treat them in a Velpo bandage for 6 weeks. Begin elbow exercises early as you see. Sometimes it's necessary to use a figure-of-8 bandage to hold the shoulder in abduction and distraction to maintain the reduction. If the reduction is unstable, which is actually the most common presentation of these, then you have several choices. One is to accept the deformity. I mean, if the patient is minimally symptomatic or asymptomatic, then you simply just accept the deformity and the bump there at the medial end of the clavicle. If the patient is symptomatic and you think that something needs to be done, then your options would include to surgically stabilize the medial clavicle or to resect the medial clavicle. And clearly, for both anterior and posterior sternoclavicular dislocations, the preferred operative treatment would be excision of the medial clavicle as opposed to attempting to stabilize it surgically. And that's an important point to remember. Posterior dislocations, if they're stable after reduction, you can treat them with a sling and swath, and again, beginning early elbow range of motion exercises. These patients can return to athletic activities at approximately 3 to 4 months. If the dislocation is unstable and you have recurrent dislocations, then again, you can consider surgical stabilization, although the preferred technique, again, would be to excise the medial end of the clavicle. The indications for medial clavicle excision would be chronic or recurrent dislocations, either anterior or posterior sternoclavicular dislocations, persistent sternoclavicular pain, so the patient's symptomatic and they have a recurrent or chronic dislocation. And it's very important that you keep the costoclavicular ligaments intact. Here are the costoclavicular ligaments here. So the excision must be performed medial to the costoclavicular ligaments, and it's recommended that you not excise more than 1.5 centimeters of the medial clavicle. If the costoclavicular ligaments are found to be disrupted at the time of surgery, then they should be repaired. So those are the important points to remember. Preserve the costoclavicular ligaments. Do not take more than 1.5 centimeters of the bone. Now, what about medial clavicle physeal fractures? You should suspect this injury in any young adult patient with a medial clavicle or sternoclavicular injury. They're usually Salter-Harris 1 or 2 fractures. Most of these injuries, fortunately, will remodel on their own and no operative intervention is required. So this is the common question that you see on your exams. They'll give you the presentation of a young adult patient with what appears to be either a sternoclavicular dislocation or a medial clavicle physeal fracture, and the correct answer is to treat them non-operatively. An anterior displaced physeal fracture, you can attempt a closed reduction to push the end of the clavicle back into its reduced position and use a figure-8 harness. Posteriorly displaced, you want to try to reduce those. If it's reducible, then it's probably going to be stable. Again, you can use a figure-8 harness. If it's irreducible, then age becomes an important factor. If the patient is less than 23, and again, you think that they have a physeal injury, then you would want to observe. If the patient is symptomatic and they're older than 23, then you would consider doing an open reduction in that situation. Now, moving on to clavicle fractures. Clavicle fractures are grouped in a way that doesn't make any sense, in that group 1 are the middle third fractures, group 2 are the lateral third of the distal clavicle fractures, and group 3 are the medial fractures. I don't understand why they just didn't go from proximal to distal, but the middle third fractures by far represent the greatest majority of clavicle fractures, 85% of all clavicle fractures. Then you see the other two types are represented more rarely, as you see listed there. Type 2 fractures, or group 2 fractures, again, are the fractures of the distal clavicle, the distal end of the clavicle, and those fractures are the ones that you really need to kind of pay attention to because they have some nuances. And group 2 fractures have been subdivided into 5 different types. Type 1 fracture, which you see here, is a fracture between the intact coracoclavicular ligaments, and those fractures will typically have very minimal displacement, can be very effectively treated non-operatively. Type 2 fractures are ones where you have an unstable medial clavicle fragment. In a 2A, which you see here, both the conoid and the trapezoid ligaments are intact, whereas in a 2B, the conoid is torn, but the trapezoid more laterally is intact. And the problem with these type 2 fractures is that the medial end of the clavicle is very unstable. The lateral end of the clavicle is well tethered by the intact coracoclavicular ligament, either the trapezoid and or both of the conoid and the trapezoid ligaments, whereas the medial end of the clavicle is going to be unstable. Type 3 fractures are ones where you have fracture that extends into the acromioclavicular joint. The medial coracoclavicular ligaments and that's a stable injury. And then the type 4s are where you have actually a periosteal sleeve with an intact coracoclavicular ligament attachment to the periosteum of the bone. This is the diagrammatic representation of that. And then type 5 fractures where you have a comminuted fracture with an intact coracoclavicular ligament to a comminuted inferior fragment. So it's basically the equivalent of the physeal sleeve injury with a mature ossified bone. The indications for acute surgical intervention in clavicle fractures, you should consider fixing clavicle fractures. And again, I'm referring now specifically to mid-diaphyseal fracture, mid-shaft clavicle fractures. If they're open, then that's, of course, an indication for operative intervention. If the fracture is significantly displaced and the fracture fragments are believed to be tinning the skin and potentially causing compromise of the skin, that would be an indication for surgery. Or if the patient has vascular injury that's going to require, exploration and repair. Those would all be good indications for operative intervention. Primary ORF has been historically reported to have a relatively high complication rate of up to 10%, and also most mid-shaft clavicle fractures will heal with non-operative treatment. So these are the reasons why ORF is not recommended on your board exam for most clavicle fractures. A questionable indication for acute operative intervention would be a concomitant brachial plexus injury. The reason that's questionable is because 2/3 of patients that have clavicle fractures with brachial plexus injury will have return of brachial plexus function spontaneously. Also, sometimes you'll see listed patients that have closed head injuries or seizure disorders where immobilization of the clavicle is not really going to be possible. That may be a relative indication for surgical intervention. The options for treating them include various intramedullary type of pin fixation techniques, or a plate, or very, very rarely you may consider putting an external fixer, although I think that would be a very unusual case. Primary non-surgical treatment for clavicle fractures, you can use a figure-of-8 brace. The bias by far of the orthopedic trauma surgeon is to treat them with a sling. Prospective studies comparing the sling to the figure-8 have not demonstrated any superiority of the figure-of-8 harness, and it really is a very uncomfortable device for a patient to wear. Now, the group 1 and 3 fractures, and again, these are the group 1 and 3 fractures referring to the type 2 distal clavicle fractures. Those patients do very well with non-operative treatment. Group 2 fractures, the group 1 and group 3 are your medial clavicle fractures and your mid-shaft clavicle fractures. Then group 2, the distal clavicle fractures, types 1, 3 and 4 that Dick mentioned can be treated very effectively non-operatively. If you have a type 3, you can consider late excision if the patient is symptomatic. And then primary surgical treatment would be indicated for the group 2 distal clavicle fractures where there is significant medial clavicular instability. And those are the type 2 fracture and the type 5 fracture. Complications are uncommon in clavicle fractures. Non-union rates are traditionally very low, anywhere from 1 to 5%. Remember that most non-unions that you will see of the clavicle will be in the midshaft of the bone. The reason for that is because 85% of all clavicle fractures occur in that area. However, if you look just at the different types of fractures, distal clavicle fractures are much more commonly have non-union in comparison of all distal clavicle fractures relative to all midshaft clavicle fractures. So the incidence is actually higher with your lateral or distal clavicle fractures. If the non-union is asymptomatic, you can treat it non-operatively. If the non-union is symptomatic, then you treat it with ORIF, and what's typically recommended is to use a plate and bone graft. Remember that, well, we're moving on now to the AC joint, acromioclavicular injuries. The anatomy, the clavicle has significant amount of rotation of 40 to 50 degrees, and about 10% of that occurs through the AC joint, and the rest of it is through scapular rotation. The AC joint is horizontally stable due to the acromioclavicular ligament. It's vertically stable due to the coracoclavicular ligaments, and then the deltoid and trapezius also act as dynamic muscle stabilizers of the AC joint. The Rockwood classification for AC injuries is commonly recognized. A type 1 is a simple sprain injury of the AC joint. A type 2 is where you do have tear of the acromioclavicular ligament, but the coracoclavicular ligaments are intact. So there'll be relatively minimal to no displacement seen radiographically. A type 3 fracture, you have both the AC ligament and the CC ligaments torn, and those patients will have significant subluxation of the joint. The type 3 injuries are the ones that typically present the therapeutic dilemma for us. Type 4s are ones where you have a type 3 injury where the clavicle is posterior displaced and basically herniated through the trapezius muscle. Those certainly need operative intervention. Type 5s are a type 3 injury where there's dramatic elevation of the clavicle by greater than 100%, up to 300%, where you can expect that the lateral end of the clavicle will be significantly prominent clinically and tinning the skin or even disrupted through the skin. And then a type 6 injury is where you have a type 2 fracture where the AC ligaments are disrupted, but the coracoclavicular ligaments may be intact, but you have inferolateral dislocation, and the lateral end of the clavicle can become entrapped under the conjoined tendon. The treatment for AC injuries types 1 and 2 are best managed non-operatively. You treat them with rest and a sling for 3 weeks, then start early range of motion, and you can anticipate that most patients will be able to return to normal activity by about 3 months post-injury. The type 3s, again, these are the ones where the AC and the CC ligaments are disrupted. The treatment of these is somewhat controversial. Most of them should probably be treated non-operatively. If you have a very elite athlete or a manual laborer that really needs to get back to full shoulder function as soon as possible, then those may be patients where it would be appropriate to consider surgical intervention to basically reduce the AC joint and stabilize it through some technique, typically through some involvement of fixation of the lateral end of the clavicle to the coracoid process. Then types 4, 5, and 6, those are the ones that clearly do have operative indications. Open reduction is indicated in repair, and the surgery that you do is based on whether you're going to stabilize the AC joint alone or also do something to reconstruct or repair the coracoclavicular ligaments, and you can also consider excision of the distal clavicle in certain situations. Now, scapula fractures are relatively uncommon. They represent less than 1% of all fractures in the upper extremity. 50% of them involve the body of the scapula or the scapular spine. When you see a scapula fracture, however, it is important to make the diagnosis because it does herald the fact that the patient really has sustained a very high-energy trauma to their hemithorax. And so you really need to be on the lookout for concomitant injuries, particularly thoracic rib fractures, pulmonary injuries seen in about a third of patients with scapular fractures. 29% of those can have, or 29% of patients can have a hemopneumothorax. Others have pulmonary contusion. Head injuries you see in about a third of patients with scapular fractures, cervical spine injuries, brachial plexus injuries, and other injuries as listed there. So the important point is that to recognize the scapular fracture is an indication of very high energy trauma, and look for other injuries, both orthopedic and non-orthopedic. Non-operative treatment is by far the preferred treatment for the vast majority of scapular fractures, and that includes the ones with glenoid involvement. 90% of scapular fractures are minimally displaced and acceptably aligned, and those are the patients certainly that will be expected to do very well with simple conservative treatment. Symptomatic treatment with a sling and early range of motion to the shoulder. You can expect union at about 6 weeks, and these patients, fortunately, will have very little to no functional deficit long term. Now, surgical indications are aimed at patients that have significant problems with rotator cuff function or stability of the glenohumeral articulation. Those would be your two indications for surgical intervention in patients with scapular fractures. So if you have greater than 25% involvement of the glenoid, these are intra-articular fractures extending into the glenoid, and subluxation of the humeral head, then that would be an indication for surgery. If there's intra-articular step-off or displacement greater than 5 millimeters, or if you have greater than 40 degrees of angulation or 1 centimeter translation of the neck fracture, which can lead to excessive medialization of the glenoid, that can cause some significant problems with rotator cuff function due to the shortening of the cuff, and those would be ones where you would consider operative intervention. And that should be done with a formal open reduction internal fixation. When performed, it is reported to have 70% good or excellent results, and the surgical approach is based on the fracture anatomy. The most commonly used approach probably is the Judet approach, which is basically going along the scapular spine and then down medially to basically lift the flap and expose the posterior aspect of the clavicle and reduce. It does allow access to the posterior aspect of the glenoid as well to reduce the articular fracture extension. Now, the superior shoulder suspensory complex is important to understand that. It's really a bone and soft tissue ring. It's composed of the different portions of the scapula, including the scapular body, the acromion process, the coracoid process, and the glenoid surfaces. Then you have the clavicle and the AC joint, and then you have multiple ligamentous and capsular supporting structures, all of which are responsible for this sort of so-called superior shoulder suspensory complex. Now, injuries to individual components of this complex are quite common and are best treated conservatively since the overall suspensory ring is not disrupted. So in other words, damaging one of these structures will not lead to disruption of the overall ring itself. However, double disruptions are ones that you need to pay attention to, and historically we believe that those, if you have a double disruption to this complex, that can lead to instability, and one part of the ring needs to be stabilized at least, and then the other part of the ring evaluated for repair. So the perfect example of that would be the patient that has a mid-shaft clavicle fracture with an associated intra-articular glenoid fracture. This is the so-called floating shoulder. A treatment that has been historically recommended that would be to perform ORF of the clavicle and then evaluate the amount of glenoid displacement that you have to consider whether glenoid fixation is necessary, and that can be done through a CT scan. However, for the floating shoulder, you should also be aware that recent studies have really questioned our thinking on this, and we're reevaluating whether any part of the floating shoulder injury needs to be surgically stabilized. And some prospective studies have demonstrated that patients treated in a sling had equal to superior clinical outcomes to patients treated surgically, and obviously without the risk of surgical complications. So the patient that I just presented to you, probably the board answer at this point for a patient with a floating shoulder with a mid-shaft clavicle fracture and an associated scapular body or glenoid injury would be non-operative treatment would be preferable. Surgical stabilization should be considered only when there's a very specific indication that we've already mentioned, such as instability of the glenohumeral joint, where you have medial subluxation, for example, significant articular displacement greater than 5 millimeters, or where you have an open injury, such as an open clavicle fracture that you're going to be in there anyway, and you should plate that, or patients with neurovascular compromise. That's a very important point. Scapular thoracic dissociations, there are two types. The intrathoracic is quite rare, and that's where the inferior edge of the scapula becomes wedged between two ribs. That can be treated with abduction of the arm, and you can reduce the disassociation in that manner. Then you immobilize the patient for 3 to 6 weeks. It's very important to do a careful neurovascular exam because of the potential for vascular disruption with these injuries. Then the lateral scapulothoracic disassociation is much more common, and that's the so-called closed traumatic four-quarter amputation. These are very serious injuries. You can diagnose it on a chest X-ray, which is non-rotated, which is a perfect PA chest X-ray that can show the scapula edge significantly laterally displaced. Vascular injuries are quite common. The subclavian artery is the artery that's most commonly damaged. You diagnose it with arteriography, and of course immediate repair is necessary to revascularize the limb. Brachial plexus injuries are quite common with these, and the brachial plexus component of these injuries is what's most responsible for the general poor outcome with scapulothoracic disassociation. So if you have a complete deficit in particular, that's a very poor prognostic indicator. You have to stabilize the dissociation to treat the patients, and typically that involves treating the clavicle with plate fixation as well as stabilizing the AC joint. Now, moving on to the shoulder. The shoulder is by far the most commonly dislocated joint in the body. The radiographic evaluation of shoulder trauma should always consist of an AP, a scapular wide view, and an axillary lateral view. And that's a very important point, because that if you get those three views, that will virtually eliminate the possibility of you missing a subtle injury to the shoulder complex. You can also consider the West Point view and the Stryker notch view, which can particularly show you a Hill-Sachs defect. Anterior dislocations are the result of external rotation and hyperextension or abduction of the shoulder. You have plastic deformation of the capsule, as well as possibly a labral avulsion, which is the classic Bankart lesion. Remember that the rotator cuff can be torn in patients that present with an acute shoulder dislocation, and particularly those patients that have a greater tuberosity fracture. And you really have to be aware of that in the older patient with a shoulder dislocation. So a patient older than 40 years old, definitely when you see a patient with a shoulder dislocation, be concerned about the possibility of damage to the rotator cuff. Glenoid rim fractures can occur with avulsion of the anterior capsular structures, and you can have the Hill-Sachs lesion, which is a posterolateral impaction fracture of the humeral head. Axillary nerve neuropraxia occurs about 10% of the time. You can follow it clinically with EMGs, and most, fortunately, will recover. And again, you also remember the possibility of an associated rotator cuff tear that may need to be ruled out. The initial treatment for an anterior shoulder dislocation, of course, is reduction, and then you need to confirm that reduction with appropriate radiographic images. If you have a young patient, you immobilize them for about 4 weeks. If you have an older patient, you immobilize them less, because, of course, the risk of dislocation is less in an older patient than a younger patient. And, of course, shoulder rehab is important. Remember that young adult patients have a very high incidence of recurrence of shoulder dislocation. If the patient is less than 20 years old, the literature says that the redislocation rate is as high as 85%. So those are the patients that where you would consider, and particularly the patient with recurrent dislocation, surgical intervention. An open labral repair has greater than a 95% success rate. And for the purpose of your board exam, it's probably best to understand the fact that, you know, at least currently, the results after open repair are superior to the results reported after arthroscopic Bankart repair. The mnemonic you can remember is the TUBS, of course, traumatic injuries to the shoulder, unilateral Bankart surgery being recommended. Now, what about inferior dislocation? This is luxatio erecta. It's pretty rare, but it's important to recognize it because it does have a very high incidence of neurovascular injury. Both the axillary nerve and the artery can be disrupted in is close to 2/3 of these patients. The axillary nerve and artery injury can resolve after reduction. However, you have to be aware of the potential for late thrombosis of the axillary artery. So these patients do need to be followed serially with clinical exams after reduction of the shoulder, because even though they may have intact pulses, after you reduce it, they can go on and develop thrombosis of the axillary artery. So you want to reduce them and mobilize them for a relatively short period of time, because these injuries are typically stable after reduction. Posterior dislocations of the shoulder are quite rare, except, it seems, on orthopedic board and in-training examinations. They really represent less than 5% of all shoulder dislocations, but the hallmark of a posterior shoulder dislocation, if you will, is a lesser tuberosity fracture. And if you have a patient that has an isolated lesser tuberosity fracture, that patient has a posterior shoulder dislocation unless proven otherwise. Clinically, the patients will be unable to externally rotate their shoulder. You rule it out by a complete radiographic series. You have to have both the axillary lateral and the scapular Y view to make the diagnosis or to rule out the diagnosis. And the clinical scenario that you'll see on your test exams where you would be thinking about a posterior dislocation would be patients that have sustained electrical shocks or patients with seizure disorders. Closed reduction is typically not difficult in the acute setting, and instability is rare with these injuries in the absence of fracture. However, the problem is that many of these injuries are missed acutely and therefore present late, and in that situation, reduction of the dislocation can be quite difficult. 50% of posterior shoulder dislocations will have an associated impaction fracture of the articular of the humeral head, which occurs between the articular margin and lesser tuberosity. And for this reason, many of these will require open reduction, and they're also typically unstable once you reduce them. You do it through a deltopectoral approach. If the impaction is less than 20%, you can treat them with closed reduction and extension. If you have a 20 to 40% defect, you can transpose the lesser tuberosity with the subscapularis into the defect. If the defect is greater than 40 to 50%, then reconstruction of the humeral head is probably not the best option, and that patient should be considered for prosthetic replacement of the proximal humerus, remembering that you want to probably place the glenoid component, the humeral component in less retroversion than you would otherwise. Vascular anatomy of the proximal humerus is important to remember. The basic thing you need to remember here is that the primary blood supply to the proximal humerus comes from the anterolateral branch of the anterior humeral circumflex artery, and that runs in the tubercular groove of the proximal humerus. There are also inconsistent contributions to the head from the tuberosities, and that becomes important in a significant four-part proximal humerus fracture, and there is some interosseous anastomosis as well. But the anterolateral branch of the anterior humeral circumflex is the dominant player. The Neer classification of proximal humerus fractures was described in 1970 and was really one of the first classification schemes that we had in orthopedics, and it's based upon the anatomic relationship of four segments of the proximal humerus: the greater tuberosity, the lesser tuberosity, the articular surface or the head fragment, and then the shaft of the proximal humerus. And a piece is considered to be a fracture part, if you will, if it's displaced greater than 1 centimeter or angulated greater than 45 degrees. A one-part fracture is typically an isolated fracture of the surgical neck of the proximal humerus, and that represents 85% of all proximal humerus fractures. On the other end of the spectrum is the four-part fracture, where not only you have a fracture through the surgical neck, but the lesser and greater tuberosities are also displaced and disrupted, and that represents 4% of all fractures, and the rest would make up 2- and 3-part fractures. The two-part surgical neck fracture, it's important to understand the deforming forces acting on that. The shaft is displaced anteriorly and medially by the pull of the pectoralis, and if the tuberosities are intact, the head typically will remain in relatively neutral alignment. If you have a greater tuberosity fracture, then the supraspinatus, the infraspinatus, and the teres minor will retract the greater tuberosity fragment superiorly and posteriorly. The three-part surgical neck fracture, which does involve the greater tuberosity, the subscapularis will internally rotate the articular segment. You can have a longitudinal tear in the rotator cuff. If you have a three-part fracture involving the surgical neck and the lesser tuberosity, you'll have unopposed pull of the external rotators, which can cause the articular surface to face anteriorly. So the articular surface will really rotate 90 degrees and be looking at you sort of directly en face, and those will also have longitudinal tears of the cuff. Then if you have four-part fractures, the tuberosities are by definition significantly displaced and disrupted. The shaft is pulled medially, again by the pectoralis, and who knows where the articular surface will be. It's variable presentation in those situations, and you can have a rotator cuff tear with those as well. The history is important for understanding the mechanism of injury. Did the patient have a concomitant dislocation of the shoulder? Did they have a seizure disorder? We've already talked about the incidence of humeral head fractures with posterior dislocations that you can see with seizure disorders. Of course, you have to do a neurovascular examination. 45% incidence of nerve injury associated with proximal humerus fractures, with the axillary nerve being the most commonly damaged. The trauma series, again, for all shoulder trauma, keep driving this point home. You want an AP, scapular Y, and an axillary view. That's absolutely essential to correctly classify these injuries on plain films. If you have 2 views alone, it's been shown that your accuracy of classification is only about 77%. If you have 3 views, then virtually it's 100% accurate classification based on the NEAR classification scheme. Additional views can include the apical oblique or the West Point view. A CT scan can be very helpful in these fractures to define the fracture anatomy and plan your surgical treatment. And if you have an suspected occult fracture of the proximal humerus, again, an MRI with a T1 weighted image would be the diagnostic procedure of choice. Now, what about operative versus non-operative treatment of proximal humerus fractures? Well, there are many, many factors that come into play. The physiologic age of the patient, of course, is an important variable. The type of fracture that's present, the amount of displacement, the quality of the bone. You may occasionally think about the hand dominance of the patient, and, of course, the overall medical condition or associated medical comorbidities. All of these factors go into defining what we refer to as the personality of the fracture, and the treatment really does have to be individualized. So the most appropriate treatment for one patient may not be the best treatment for the next patient that you see. For one-part fractures, these are stable. You treat them with early range of motion. If they're unstable, you may consider a brief period of immobilization and begin range of motion when the shoulder moves as a unit. For anatomic neck fractures, not through the surgical neck, but through the anatomic neck, these are quite rare. If you see them in young patients, they should be treated with open reduction and internal fixation. In elderly patients, you can consider ORF, or you may also consider hemiarthroplasty. If they're comminuted, then hemiarthroplasty would be the treatment of choice. For 2-part fractures involving the lesser tuberosity, again, think about the possibility of a concomitant posterior shoulder dislocation. Again, an isolated lesser tuberosity fracture is a posterior shoulder dislocation until you prove that it's not. If you have a large fragment, the lesser tuberosity is a large fragment, you can treat that with ORIF. If you have a very small fragment, you can excise it and do a primary rotator cuff repair. Greater tuberosity fractures, you really can tolerate very little displacement of greater tuberosity fractures because of the fact that any displacement of the greater tuberosity can really significantly impinge and block external rotation and abduction of the shoulder. So you want to accept very minimal displacement of the greater tuberosity in patients that do not have medical contraindications to surgery. The treatment is an open reduction and fixation, either with screws or screws and a combination of a tension band. Surgical neck fractures are the most common fractures by far. Again, the 2-part surgical neck fracture is the most common proximal humerus fracture that we see. If you have greater than 45 degrees of angulation, then you can consider closed treatment or operative treatment rather. Posterior angulation is better tolerated than anterior angulation. If you have anterior and particularly varus angulation of the fracture, that's generally poorly tolerated and may be an indication for surgery. Surgical treatment can consist of percutaneous pinning. There are many advocates of that. Plate fixation with our new proximal humerus locking plate techniques, that may be the treatment of choice in some physicians' hands. Ender's rods with a tension band have been used historically as well, or you can use an intramedullary device with proximal fixation into the humeral head, such as is shown here, and that's a very effective treatment for these fractures, 2-part fractures, where you have surgical indications. Now, 3-part fractures, closed reduction is generally been historically associated with poor results, and NEAR described no successful results with closed management of 3-part fractures. Young in British JBS 15 years later had 70% successful results. And then in 1997 in the British JBJS, Zyto looked at a prospective review of 37 patients and basically reported similar functional outcomes in patients treated operatively versus those treated non-operatively. So the point of this is that over the years, there has been a trend away from aggressive surgical treatment towards non-operative treatment of many patients with 3-part fractures. And it's clearly been shown that patients that are treated with surgically do have, of course, a higher complication rate. So this is a direct quote that Dick put in here from, I believe, the Academy, which says that in general, the trend for 3-part fractures has been toward the avoidance of plate and screw fixation due to the fact that there's a high incidence of postoperative pain, disability, osteonecrosis, non-union, malunion, and other complications. With these fracture patterns, prosthetic replacement with tuberosity reconstruction is probably a more reasonable treatment alternative in elderly patients. So there you have it. That's the official statement from the Academy. And for most three-part fractures in elderly, debilitated patients particularly, then prosthetic replacement with proximal humerus is probably the treatment of choice in comparison to ORF. What about the three-part fracture in the young patient, however? These are ones that we would not think would do well with a prosthetic replacement of the proximal humerus, and ORF is indicated. You can do a percutaneous pinning. It has the benefit in that it does protect the axillary nerve and presents complications from a big wound and big dissection. You can use plate fixation. A T-plate has historically been associated with poor results. Does not provide secure fixation of the proximal humerus. Also, it has to be placed quite proximally to get adequate fixation, and therefore can cause impingement. So you'll have loss of fixation, malunions, infections, and it's not recommended. More commonly now, what we're using for plate fixation is either a proximal humerus blade plate or, even more recently, a proximal humerus locking plate, which really does provide excellent stability to the proximal humerus. And also, you have to place the plate much less proximally, so that eliminates the possibility of impingement, and does give you very stable fixation. For certain fractures, you can consider also intramedullary fixation with proximal fixation of the intramedullary implant into the humeral head, and can provide very stable fixation. Also can allow you to reduce and fix the tuberosities to the implant itself. Now, in a young patient with a four-part fracture, that's a very severe injury. Again, both the greater and lesser tuberosity are disrupted, and that's the young patient where you would probably consider a hemiarthroplasty as the treatment of choice. With your technique, you want to restore the height of the proximal humerus, so avoid sinking the prosthesis down into the humeral shaft. And of course, it's very important that you reattach the tuberosities to the shaft to restore rotator cuff function to the patient. What about the valgus impacted four-part proximal humerus fracture? That's a kind of a unique injury. You'll have variable tuberosity displacement, and these do have typically good to excellent results with ORF in the 75% range, so 3 or 4 of them. And what you have with these fractures is this is basically an impaction injury, where the humeral head is rotated about 90 degrees into valgus because of the impaction of the shaft and the subsequent split of the tuberosities. If you have the posterior medial component of these intact, that preserves the intraosseous blood supply, and these patients will have a low rate of osteonecrosis, which is different than other four-part fractures. So ORF for the four-part valgus impacted fracture, you want to elevate the articular segment, restore it into normal continuity with the glenoid, fill the resulting defect with bone graft material, and repair the tuberosities. Rehabilitation is a very important part of the treatment of patients with proximal humerus fractures. It's critical that these patients get good shoulder therapy and that they understand that their end result may not be achieved for up to 9 to 12 months post-injury, and that therapy is going to be necessary through that time period. The best results clearly have been shown with a guided, dedicated post-operative therapy program. Early range of motion is what you want to emphasize in the first 6 weeks, to passive range of motion. Then you want to start active range of motion and progressive resistive exercises. Then finally, the third phase of the recovery would be stretching and strengthening and work conditioning type exercises. Proximal humerus fracture complications are due to both the injury and the fracture as well as the treatment. The most common complication that we see is the missed posterior dislocation. So remember again, the patient with the lesser tuberosity fracture, keep driving this point home, you must recognize and rule out the possibility of a posterior shoulder dislocation. Adhesive capsulitis or frozen shoulder is a very common complication in patients with proximal humerus fractures. You can get malunions, particularly varus malunions, non-unions of either the surgical neck or the tuberosity fractures. Osteonecrosis, when that happens, there's basically no salvage for that other than total shoulder replacement. Rotator cuff injuries and dysfunction related to the rotator cuff problems are quite common, of course, with proximal humerus fractures. And as mentioned, the incidence of axillary nerve injury is up to 10%. And you can also have brachial plexus problems. Now, we're going to move on down and talk about humeral shaft fractures. Remember that for most humeral shaft fractures, the treatment method of choice is non-surgical in a very simple Sarmiento-type functional brace, as is shown here. You can treat the patient with a coaptation splint for 7 to 10 days while they are having acute swelling. Then once the swelling goes down, you can fit them with a cast brace, and excellent healing and functional recovery is expected in 95% of these cases. There is a very low non-union rate. If you have a significant varus deformity of 8 degrees, then those are the patients where you may see a higher incidence of non-union. Complete return of shoulder and elbow function as well as range of motion is expected in the vast majority of these fractures. And even if you have a very distal comminuted fracture, 96% of those have been treated successfully to union if you have the appropriate alignment in the fracture brace with minimal varus. So what are the acceptable, what is an acceptable alignment for a humeral shaft fracture? You can expect a good functional result without compromise of either shoulder function or cosmesis if you have less than 20 degrees of anterior angulation, less than 30 degrees of varus valgus angulation, and less than 3 centimeters of shortening. So those are the criteria, if you will, for an acceptable closed treatment, and the vast majority of humeral shaft fractures will fit those criteria. Brace considerations, remember that if you have a patient that has severe associated soft tissue injury, then a brace might not be possible in that patient. If you have an unreliable patient, or if you have an inability to either obtain or maintain an acceptable reduction in the brace, those would all be potential indications for surgical intervention. So the surgical interventions or indications are based on the fracture itself as well as the patient conditions. There are some so-called absolute indications for operative intervention. Those would include, of course, open fractures, where you're going to need to explore the wound and treat the soft tissue component of the injury, vascular injuries that are going to require operative repair. The humerus absolutely needs to be stabilized in that situation. If you have a floating elbow injury, where you have a humeral shaft fracture in conjunction with a both bones forearm fracture or an isolated radius or ulnar shaft fracture, those patients need operative intervention. And, of course, if you have intra-articular fractures of the distal humerus, that would be an indication for surgery. Relative indications would include failure of closed treatment or either lack of patient compliance or poor body habitus, where bracing is not possible. Segmental fractures will not do well with brace treatment, or bilateral humeral shaft fractures, that would be an indication for operative intervention. The polytraumatized patient, that's a very common indication in my hands for operative treatment of humeral shaft fractures, where you want to be able to immobilize the patient as early as possible, and with intramedullary nailing of a humeral shaft fracture, you can consider allowing the patient to return to weight bearing using that extremity much faster. You also see other indications: multiple fractures, closed head injuries, burns, chest trauma, associated brachial plexus injuries, nerve injuries after reduction. That's a controversial topic which we'll cover in a moment. If you have a delayed union or a non-union of the bone or a malunion or an infection, those would certainly be indications for operative intervention. Pathologic fractures, intramedullary fixation is a very good option for pathologic fractures of the humeral shaft, and in certain neuromuscular conditions such as Parkinson's disease. ORAF is associated with a very high success rate if it's done properly, and that's the key component. You have to use the appropriate plate, and you have to get adequate fixation, and you have to get, of course, a good reduction. If the technique is done properly, then you can expect greater than a 90% union rate. You need to use a 4.5 millimeter dynamic compression plate. Do not try to use a smaller plate, a 3.5 plate. You need to use a large fragment dynamic compression plate. Either the broad or the narrow 4 or 5 DCP will work. I would prefer the broad plate because it has offset of the screws that gives you a decreased risk of crack propagation. And remember that you must have a minimum of 6 cortices of fixation above and below the fracture of the humeral shaft. If you have less than that, then you're going to be at an increased risk for an unstable fixation construct and non-union. Preferably, you'd like to have 8, but the board answer probably is 6 cortices of fixation. What about intramedullary nailing of humeral shaft fractures? Well, multiple different interlocking techniques are available. Intramedullary nailing of humeral shaft fractures has traditionally had kind of a bad reputation, if you will, in the literature due to both relatively high incidence of non-union as well as significant problems with shoulder function postoperatively. The one caveat, however, is that intramedullary fixation is probably the treatment of choice in the polytraumatized patient with associated lower extremity fractures, where the patient is going to need to maintain a protected weight-bearing status for a period of time. Intramedullary nailing can adequately stabilize the humeral shaft and allow you to use that extremity as a weight-bearing extremity. External fixation in humeral shaft fractures is typically reserved for patients that have large, open, soft tissue wounds, significant bone loss, or patients that have burns where soft tissue management is a problem, or infected non-unions. Sometimes it can be used, again, in damage control orthopedics as a good initial treatment before conversion later to a more definitive type of fracture management. Non-unions of the humeral shaft is an important point that seems to come up often on board exams and in-training exams. If you have a non-union of a humeral shaft fracture, the treatment of choice is open reduction and plate fixation. Again, using a 4.5 millimeter dynamic compression plate as well as bone graft if necessary, adequate fixation, a minimum of 6 cortices, preferably 8 if possible. This is a 4.5 millimeter reconstruction plate, and I do not think that this is appropriate treatment for this humeral shaft. I assume this is a humeral shaft non-union. This plate is nowhere near as strong as a 4.5 millimeter DCP, and this would not be the best treatment for this humeral shaft. You can also consider if you have significant bone loss or a segmental defect of vascularized fibular graft, and electrical stimulation with an implantable electrical stimulator has been shown to have some limited success in treatment of humeral shaft non-unions. And this is that case that here's a non-union that's treated with a rigid 4.5 plate and bone grafting, again, minimum of 6 cortices, and that what he's showing here is that this case here went on to a non-union because of inadequate initial fixation, and then this is how it's salvaged with the appropriate plate, adequate fixation above and below the level of non-union, as well as bone grafting. Neurovascular examination in humeral shaft fractures is a very critical point because, as you know, many humeral shaft fractures are associated particularly with radial nerve injury. So the radial nerve is at the highest risk in fractures of the middle or distal 1/3 of the humeral shaft, and the incidence is anywhere from 2 to 18%. Neuropraxia is the most common type of injury that you see, and 70% of these, or over 70%, will spontaneously recover over a period of about 3 months. So the recovery is actually expected to take quite a few weeks, and that's something that you need to counsel the patient about. And this is why most commonly when we see patients with radial nerve injuries with humeral shaft fractures, observation is the treatment of choice. If you have a transverse fracture, those are the ones that are most commonly associated with neuropraxia, and you really have to be aware of the Holstein-Lewis fracture, which is a spiral fracture of the distal 1/3 of the humeral shaft. Those are the fractures where the radial nerve can actually become entrapped in the fracture site. Radial nerve palsies, the management of those. If you have a closed fracture with a complete radial nerve deficit on presentation, the initial management, again, should be observation. Most of those, approximately 3/4 of those, will spontaneously recover over a period of about 3 months. You can consider doing electrodiagnostic studies at about 6 weeks. If you see fasciculations on your EMG, then that's evidence of reinnervation occurring, and you should continue observation. If there's denervations with fibrillation potential, then you could consider surgical exploration once you have your electrodiagnostic evidence of a significant injury. What are the surgical indications for acute exploration of the radial nerve? Well, if you have an open fracture that you're going to be performing an open procedure to obtain plate fixation, usually of the humeral shaft, or if you have a patient with a vascular injury. And for other indications, it's controversial. If you have a palsy following a closed reduction, so you perform a closed reduction maneuver, you put the patient in a fracture brace, and the patient who previously had an intact neurologic exam now has evidence of radial nerve injury. When I was a resident, there's no question that the correct answer for that patient had to undergo surgical exploration. However, recently this has been looked at, and it's now understood that, again, most of these patients have a neuropraxia, and the nerve recovery will occur spontaneously in the vast majority of the cases, and those patients do not necessarily need surgical exploration. The one exception to that would be the Holstein-Lewis fracture, where because of the fracture anatomy, again, it's a spiral fracture, the distal 1/3 of the humeral shaft. If you do a reduction maneuver, the radial nerve can become entrapped in the fracture site, and if you have a radial nerve palsy post-reduction, those patients probably warrant surgical exploration. So if you have a closed fracture where you have an anatomical reduction, however, of a Holstein-Lewis fracture, those patients would be expected to have a very low risk of nerve entrapment because of the fact that the fracture is anatomically reduced. You can treat those patients with electrodiagnostic testing at 6 weeks. On the other hand, if the fracture seems to be irreducible or there's evidence of soft tissue interposition, then those patients should be explored. And again, these are patients that have neurologic deficit post-reduction. Now, we're done with the humeral shaft. We're going to move on down to the elbow now and start talking about the very difficult distal humerus fractures. These include both periarticular fractures with extension into the joint as well as extraarticular or supracondylar fractures. The avulsion fractures are extraarticular. Medial avulsion fractures, much more common than lateral. If the patient has ulnar nerve symptoms or greater than 1 centimeter displacement or instability of the elbow joint due to disruption of the ligamentous restraints, that would be an indication for ORIF. If you have a metaphyseal fracture or supracondylar fracture of the distal humerus, that by definition causes disruption of both the medial and the lateral columns. Those should be treated with ORIF. And just as with intra-articular fracture of the distal humerus, remember that the most stable construct is dual plates, 2 plates, placed at 90 degrees relative to one another. So typically this means a plate placed along the medial aspect of the distal humerus and a second plate placed posterolaterally. So 2 plates, 90 degrees relative to one another. Articular fractures can include both medial and lateral humeral condyle fractures. The Milch classification scheme is indicated here. And for both medial and lateral condyle fractures, remember that with a Milch 1, the lateral trochlear ridge is going to be intact. And that makes these fractures stable as opposed to Milch 2, where you do have violation of the lateral aspect of the trochlear ridge. So for Milch 1s, if they're non-displaced and they're stable, you can treat them with early range of motion. For a Milch 2, they are by definition unstable, and those need to be treated with open reduction and anatomical reduction of the joint surface. For pediatric considerations, remember that a Milch 1 is actually a Salter-Harris 4, and a Milch 2 is a Salter-Harris 2, and I'm sure that's probably covered with you in your pediatric lecture. Capitellum fractures are quite rare, but they can be significant. They're divided into types 1, 2, and 3, as you see here. I doubt that you would ever be tested on recognizing those different or classifying them. But it's important to recognize them. They're frequently associated with radial head fractures and posterior dislocations of the elbow. You must assess the range of motion for a possible mechanical block. A displaced capitellar fracture can actually function as a mechanical block to elbow flexion. If you have subtle capitellar irregularity, that would be suggestive of a sleeve fracture, a type 2 fracture, and CT scan can also be helpful in that diagnosis. If you have a non-displaced capitellar fracture, less than 2 millimeters displacement, you can treat those with early range of motion and close radiographic follow-up. If the fracture is significantly displaced and the fragment is large enough, you treat it with ORIF. It's a displaced small fragment, then you treat those with fragment excision. Now, what about intra-articular distal humerus fractures, intercondylar fractures of the distal humerus that have disruption of both columns? There are 2 factors that have been proven reliable for an acceptable outcome. The first is to obtain an anatomical reduction of the articular surface. The second factor then is to obtain stable fixation of the articular segment of the bone to the shaft of the bone, and again, you think of these as with a dual column approach, and that means dual plate fixation of both the medial column and the posterior column. And then the third factor that's been very critically shown to be associated with good results is early mobilization of the elbow joint, and of course that necessitates you to obtain stable fixation. Typically, these are performed through a posterior approach. You can either do a triceps reflection, or more commonly, an osteotomy of the ulna of the olecranon is indicated. And it's really critically important that you have adequate visualization of the articular surface of the distal humerus in order to obtain an acceptable result, because that's necessary to anatomically reduce the articular fracture extension. You have to be aware of the possibility of ulnar nerve injury with these approaches, and it's very important that you isolate and protect it. Whether or not you transpose the nerve is still a subject of debate among trauma surgeons, probably 6 to 1, half dozen the other. There's nothing in the literature that mandates that you have to do an anterior nerve transposition. Articular reconstruction is critically important to anatomically reduce the intra-articular fracture extension, then dual plating and early range of motion, as we mentioned. Complications of distal humerus fractures, non-unions can occur anywhere from 1 to 10%, and that's usually due to poor surgical technique, inadequate or unstable fixation. You can occasionally get a non-union of your olecranon osteotomy. If you do the osteotomy correctly, however, that's quite rare, and for that reason, a chevron type osteotomy, as is seen here, is the preferred technique. That allows you to get more stable fixation because the olecranon fragment really locks into the proximal ulna. You have a greater surface area of cancella surfaces for healing, and you can get very good compression with intramedullary fixation across that olecranon osteotomy. Other complications, ulnar neuropathy is probably one of the most common problems in these fractures. It's especially seen in patients that have non-union of the distal humerus with a valgus deformity. Transposition of the ulnar nerve can minimize the incidence of this by minimizing your impingement in the hardware. Again, there's nothing in the literature that clearly shows that ulnar nerve transposition is necessary in these fractures. Heterotopic ossification, beware of this, particularly in the patient with a closed head injury. Also also patients with severe soft tissue injury and patients in which you need to do an anterior approach to the elbow. HO is much more common in the anterior elbow than the posterior elbow. Also, if your surgery is delayed for any reason, that patient's going to be at a higher risk for heterotopic ossification. You want to prophylax against it. Radiation therapy is very effective, and excise it when it develops. The question always comes up about when to do your excision. Traditionally, we've always been taught that you wait until the bone is mature, although with recent articles there has been a trend towards earlier excision and then postoperative radiation therapy. The Mori classification is useful for fractures of the olecranon. Type 1 fractures are truly non-displaced fractures. Those are actually quite rare. Of course, the mechanism of injury of an olecranon fracture is an axial load to the elbow, and the distal humerus is literally driven through the articular surface of the proximal ulna. So for that reason, it's quite rare to have a non-displaced fracture. If you do, you can certainly treat them non-operatively. You can splint the elbow between 45 and 90 degrees of flexion, and of course follow them with serial radiographs. Displaced fractures of the olecranon should be treated with ORIF. A type 2A fracture is one that it has minimal comminution and where the fracture of the proximal ulna does not extend distal to the coronoid. These fractures typically are quite stable and will do very well with conventional tension band wiring technique for surgical fixation. You can use a K-wires, as is shown here, plus your tension band wire. You can use an intramedullary screw, which is the technique that I prefer to use. Either one of those techniques will work quite well for these stable fractures. Type 2Bs are the ones where you have significant comminution, and you may also have fracture extension distal to the coronoid process. If you have either one of those factors, significant comminution of the proximal ulna or distal fracture extension distal to the coronoid process, those fractures are very unstable and will not do well with conventional tension band techniques. Those are the patients that you need to consider plate fixation of the proximal ulna is the best treatment of choice. And you can place the plate posteriorly, as is shown here, although that's not the technique that I prefer because of the significant prominence of the hardware posteriorly. More commonly, we'll place it along the medial aspect of the proximal ulna. And there are very good periarticular plating systems now available. What about excision of the olecranon? This is probably really of historical significance only. It is in the literature, however, that you can remove up to 50% of the proximal portion of the ulna and reattach the triceps in certain cases where there's a highly comminuted fracture that's very unstable and achieve reasonably good results. If you take more than 60% of the olecranon, however, you can get significant instability of the elbow joint, or if there's an associated coronoid fracture present. And either transverse or oblique fractures can be excised, and advocates of this technique historically recommended that this eliminates articular incongruity and potential for post-injury degenerative arthrosis. Again, with current fracture fixation techniques, this is probably really not the preferred treatment for virtually any fracture of the proximal ulna. Coronoid fractures are quite difficult both to assess and to manage. The coronoid process is important for anterior stability of the elbow joint. It functions as an anterior buttress in the greater sigmoid fossa. And remember that it is important, and that is the site of attachment of the anterior bundle of the medial collateral ligament. That's the important portion of the medial collateral ligament. And if the coronoid is disrupted, particularly disrupted at its base, you can anticipate significant injury to the medial collateral ligament associated with that. Isolated coronoid fractures are rare. It's usually seen in combination with elbow dislocations or injuries of the proximal ulna or the radial head. You have to look for those injuries and rule them out. And if you have a patient that has an elbow dislocation, you can anticipate that if there is a concomitant coronoid fracture, that the elbow is likely going to be unstable post-reduction, particularly with large coronoid fractures. The Mori classification of coronoid fractures is based on the size of the coronoid fragment. A type 1 is just a shear fracture. That's caused by subluxation of the elbow and does not represent avulsion. Type 2 fractures can involve up to 50% of the coronoid process. Those are seen with elbow dislocations and radial head fractures. And type 3s are one that are much more significant involvement and actually extend into the olecranon process itself, and those can be very unstable. The treatment of coronoid fractures is you treat the associated injuries, the elbow dislocation, the radial head fracture, the olecranon fracture, as mandated for the treatment of those injuries individually, and then you can perform an ORF of the coronoid process itself when there is significant stability, and that can be done with either a screw fixation or a non-absorbable suture, and the goal is to obtain stable reduction of the elbow joint so that you can begin early range of motion. Radial head fractures, head and neck fractures occur in 50 to 60% of elbow dislocations, so you really have to look for those when you see a patient with an elbow dislocation. The mechanism of injury is typically an axial load onto a pronated forearm. You have to evaluate the ipsilateral distal radial ulnar joint and the wrist because of the possibility of damage to the interosseous membrane with these injuries. And the fracture is most common in the anterolateral portion of the radial head, and that's significant, and that is an area where there is typically a little articular cartilage and the subchondral bone is the weakest. That's why it fractures in that area. The radiographic imaging of radial head fractures, an AP, a true lateral, and sometimes you can get this radial head capitellum view, which is taken with the beam oriented 45 degrees to the flexed elbow as you see here, and that can really show you very clearly both the capitellum and the radial head. The Mason classification system, type 1 fractures are minimally or non-displaced fractures defined as less than 2 millimeters of intra-articular displacement. There typically will be no mechanical block to elbow range of motion in these fractures, and they will do quite well with simple conservative non-operative treatment. Type 2 fractures are where you have displacement of either the head itself greater than 2 millimeters or displacement of the neck with angulation. Those fractures, you can have a significant mechanical block to elbow range of motion, as well as potential for post-traumatic arthrosis of the radiocapitellar joint, and those fractures would be ones that could be considered for operative intervention. And then the type 3 fractures are where you have severe comminution with displacement and angulation of the radial head or the neck. So type 1 fractures, make sure there's no mechanical block. You may need to aspirate the joint and inject it for pain control to do your clinical examination and assure that there's no mechanical block. And you treat those with early range of motion. Treat them with a sling or splint for just a few days and allow them to start in range of motion because these are stable injuries as soon as their pain tolerance will allow. You can expect that there may be some loss of extension, usually less than 15 degrees with appropriate treatment. For type 2, you want to fix the radial head and or the radial neck when possible. Beware of associated injuries, either elbow dislocations, distal radial ulnar joint injuries, or damage to the interosseous ligament. A CT scan can be helpful. Typically, the simple type 2 radial head fractures can be very effectively managed with screw fixation of the radial head fragment, as you see in these radiographs here. Type 3 fractures. The take-home point here is to remember that acute excision of the radial head is never indicated without doing something to replace it. So do not excise the radial head and leave it without some sort of concomitant radial head replacement. We try to fix every radial head that we can. If the fracture anatomy will allow you to get fixation, and there are periarticular plates available now for the proximal radius that will allow you to get good fixation, even locked fixation into the radial head and neck, you should try to preserve the radial head. If you think that the radial head is not reconstructible, then you excise it and replace it with a prosthetic implant, a metallic implant, not a silastic implant. So surgical approach to the radial head is typically the Coker approach, using the posterolateral. It goes between the anconeus, innervated by the radial nerve, and the extensor carpi ulnaris, innervated by the posterior osseous nerve. You want to keep the arm pronated during your approach to protect the posterior osseous nerve. And remember that you have to place your hardware within the so-called safe zone, which is basically a 110-degree arc of the humerus where it's safe to put your screws. If you go outside that arc, then you're going to run the risk of impingement on the articulation between the proximal radius and the ulna. The Essex-Lopresti lesion is a sort of a peculiar injury where you have a radial head fracture with interosseous membrane disruption and associated dislocation of the distal radial ulnar joint. Again, that's why when you have a patient with a radial head fracture, you have to radiographically image the entire forearm, including the distal radial ulnar joint, to rule out the presence of an Essex-Lopresti lesion. The clinical findings will be the ulna is displaced dorsally relative to the radius, or the DRUJ is dislocated. the hand will be present with radial deviation, and the patient will have virtually a complete block to supination. The treatment of this, again, do not resect the radial head. Treat it with either ORIF or prosthetic replacement, and the reason this, of course, is to prevent proximal migration of the radius. Prosthetic replacement, silastic head implants will not prevent proximal radial migration, and they have been shown to be associated with significant silicone synovitis. So for that reason, the silicone radial head implant should not be used. So use a metallic head implant. They've been shown to be associated with improved results. You can expect that there may be some loosening. And now that we have modular implants that are available, the results have been even better. Prosthetic replacement is indicated, of the radial head is indicated for patients where you have significant elbow dislocation and instability, also the Essex-Lopresti lesion. And remember that you have to fix the lateral collateral ligament and the associated coronoid fracture if those injuries are present concomitantly. Now, moving on to elbow dislocations, you define them as relative to the position of the forearm, relative to the humerus. So this would, of course, be a posterior dislocation. The posterolateral is the most common type and represents greater than 80% of all elbow dislocations. The other types that indicated there are less common. Associated injuries with elbow dislocations are the rule, actually, rather than the exception. You can have radial head and neck fractures and up to 50 to 60% medial lateral epicondyle fractures, coronoid fractures, and you especially want to beware of the so-called terrible triad of the elbow, which consists of an elbow dislocation with an associated coronoid fracture and a radial head fracture. Those will require operative intervention. The functional anatomy of the elbow, remember that the primary stabilizers are the ulnar-trochlear articulation itself. You know, of course, the distal humerus, the trochlea is recessed into the proximal portion of the ulna. Then you have the anterior band of the medial collateral ligament, which is, again, the most important medial primary restraint. And, again, that attaches directly to the base of the coronoid process. So that's suspected to be disrupted in significant coronoid fractures. Then the ulnar portion of the lateral collateral ligament. The secondary stabilizers then would be the radial head, the capsular attachments, and the various muscles that cross the elbow joint. The medial collateral ligament is the primary stabilizer of the elbow. It allows resistance to valgus deforming force along with the lateral column itself, which consists of the radial head and the capitellum. There are three components. There's the anterior oblique band, which is the primary stabilizer and inserts, again, at the coronoid process. Then you have the posterior oblique band and the transverse band. So, again, the medial collateral ligament is the primary medial stabilizer of the elbow joint, especially the anterior band. In full extension, it provides 30% of the valgus stability. In 90 degrees of flexion, it provides over 50% of the valgus stability. And when you have more extension, then you can more rely on the intact lateral bony column for your stability. Resection of the anterior band of the MCL will cause gross instability of the elbow joint except in extension. And again, this goes back to why we try to fix the significant coronoid fractures, because that restores the proper anatomical relationship of the medial collateral ligament and will prevent late instability. The lateral ligaments are responsible for prevention of posterior subluxation and rotation of the ulna, and if they're disrupted, you can get posterolateral rotatory instability. That can be let's go back to treatment of elbow dislocations. The initial treatment of all dislocations, of course, is non-surgical. You anatomically reduce the ulnotrochlear articulation. Then you want to check the range of motion and stability post-reduction by taking the elbow both into full extension and full flexion whenever possible. And typically this can be done with a relatively minimal sedation in the emergency room to get the elbow reduced. Post-reduction films are necessary to rule out concomitant fracture and confirm your reduction. If you have a stable reduction, then you splint them in 90 degrees of flexion for several days and then begin early range of motion. If you have an unstable reduction, you may consider immobilizing the elbow for up to 2 to 3 weeks. If you immobilize them greater than 3 weeks, that has been shown to be detrimental with long-term functional outcomes with increased risk of significant elbow stiffness. So simple dislocation results depend heavily on how long they're immobilized. Again, with the adult elbow, it's almost never indicated to immobilize the adult elbow greater than 2 weeks, and that's kind of a thing you want to remember. And there's no clear advantage to surgical repair of either the medial or lateral ligaments acutely in simple dislocations. Now, elbow dislocation can lead to a spectrum of instability, which is diagrammatically represented here from stage 1 to 3. Stage 1 is the posterolateral rotatory subluxation. Stage 2 is where you have perch or incomplete dislocation. with damage to the anterior capsule. And stage 3 is the end result of this type of syndrome, where you have either a partial or complete tear of the medial collateral ligament, and it's the anterior band of the MCL again, which is the primary restraint primary medial stabilizer of the elbow. Now, how can you test for valgus instability? And these are the patients where you would suspect posterolateral rotatory instability. You can do this pivot shift test, if you will, by applying extension, valgus, and supination forces. If you get subluxation, then that's an evidence of a positive pivot shift test and posterolateral rotatory instability. You can reduce it by applying flexion and pronation, and usually surgical treatment is necessary for these to reconstruct the lateral ulnar collateral ligament. And Mori results have reported 80% successful results in these patients with significant posterolateral rotatory instability secondary to damage to the lateral collateral ligament. Now, moving on down to the forearm. Now, radius and ulna fractures, non-operative treatment really has very limited indications for forearm fractures in adult patients. The one exception to that where you can consider non-operative treatment is in the isolated ulnar shaft fracture where you have appropriate alignment. And these would be distal 2/3 ulnar shaft fractures, not proximal ulnar shaft fracture, but distal 2/3 fractures where you have less than 50% displacement and less than 10 degrees of angulation. Those fractures have been shown to do quite well with conservative closed treatment in a functional fracture brace, union rates over 96%. If you have a proximal 1/3 ulnar shaft fracture, or if you have greater than 50% displacement or greater than 10 degrees of angulation, those are the ulnar shaft fractures that warrant formal ORIF. Now, a non-displaced radial shaft fracture is something that's quite rare. When you see it, there's a temptation, of course, to treat those non-operatively. However, you must be certain that the radial bow is maintained, because that's the most important determinant in forearm fractures with restoration of forearm pronation and supination. You can also get delayed healing of these because the ulna itself is intact, and probably for even non-displaced radial shaft fractures, ORF is the preferred treatment option. The ORF for both bone forearm fractures is typically performed through separate approaches. Resist the temptation to try to reduce these through a single approach because of the very high risk of synostosis of the forearm caused by that. You typically will want to do a volar or Henry approach for treatment of radial shaft fractures. It's extensile. You can literally expose the entire length of the radius. It utilizes the interval between the brachioradialis and the pronator teres proximally, and the flexor carporadialis distally, and of course that is an internervous plane. For proximal 3rd radial shaft fractures, occasionally the dorsal or Thompson approach can be indicated. That does place the posterior osseous nerve at risk, and you can reduce that risk by maintaining the forearm in pronation. It utilizes the interval between the ECRB and the extensor digitorum communis proximally and the EPL distally. For ulnar shaft fractures, those are approached through of course the ulna has a subcutaneous border, and you can approach the ulnar shaft quite easily through an internervous approach between the extensor carpi ulnaris and the flexor carpi ulnaris. The standard technique for plate fixation of ulnar shaft fractures should be use of a small fragment 3.5 millimeter dynamic compression plate. Again, you do not want to use a recon plate. You do not want to use a 1/3 tubular plate. You should use a 3.5 millimeter DCP for adequate fixation of the forearm. What about intramedullary nailing? That has been looked at, really is no longer advocated due to the fact that you cannot get adequate rotational stability, you cannot get adequate axial stability, and it's very difficult to maintain the radial bow. And again, the most important determinant long-term with functional outcome in forearm fractures is to anatomically restore the radial bow. Postoperatively, you treat them with a splint and early range of motion exercises unless you have significant proximal or distal joint injury to the elbow or the wrist, respectively. Galeazzi fractures, a couple eponyms you probably need to remember. The classic Galeazzi fracture is a fracture of the distal 1/3 of the radial shaft with an associated dorsal dislocation of the ulna, or a distal radial ulnar joint injury. We now will commonly refer to a fracture as a Galeazzi fracture if there's any forearm fracture with an associated DRUJ injury. The treatment is to perform anatomical plate fixation of the radial shaft and then stabilize the DRUJ. If the DRUJ is irreducible, you should suspect interposition of the extensor carpi ulnaris tendon. That needs to be removed. Your treatment for the DREJ injury can consist either of immobilization of the patient for 6 weeks and supination. I think quite more appropriately is to do surgical stabilization with pin fixation across the DRUJ, and that can allow you to keep the patient out of a long splint immobilization of their wrist and their elbow. And the pin can, of course, be removed in the office, and you typically will leave the pin in for about 4 weeks. What are the radiographic signs of DREJ injury you can look for? Well, you can look for the presence of an ulnar styloid fracture, a large ulnar styloid fracture. On the AP view, you can look for widening of the joint. This is diagrammatically represented here. You can either, this is abnormal widening of the DREJ here. On the lateral view, of course, you're going to look for dorsal dislocation or dorsal displacement of the ulna relative to the radius. And you also want to look for radial shortening, which you also see evidence of here. This is a classic of a Galeazzi equivalent, if you will, and this is treated with ORF, plate fixation of the radial shaft, and stabilization of the ulnar styloid fracture. The Monteja fracture involves dislocation of the radial head associated with a fracture of the ulnar shaft. The significant thing about a Monteja injury is 20% of them can present with posterior osseous nerve injuries. There are types 1 through 4 described. You will not be tested on recognizing those types, but the important fact is to remember that there can basically be different types of displacement of the radial head, either anterior, posterior, or lateral, and that's how you classify them. The treatment is to perform anatomical plate reduction and fixation of the ulnar shaft, and then close reduction of the radial head. In the vast majority of these injuries, the radial head will be stable in reduction once the ulnar shaft is anatomically reduced. What about complications in forearm fractures? Well, complications can occur both to the injury itself as well as your treatment. You can have a compartment syndrome in forearm fractures, and that's important to remember. The patient that has sustained a high-energy crushing type injury, as well as patients with severe open fractures, low-velocity gunshot wounds, patients that have vascular disruption or coagulopathy. And again, the physical examination is critically important in these patients looking for pain with passive stretch. Neurovascular injuries are quite uncommon in closed fractures, except for the posterior osseous nerve injury that you can see with Monteja fractures, as I mentioned. The one instance where you can see nerve injuries is in type 3 open fractures, and this can dramatically affect the outcome because typically these are not neuropraxias. They are significant nerve injuries due to the associated significant soft tissue injury, and those have a relatively poor prognosis. One thing that you can also need to be aware of with forearm fractures is the possibility of refracture following removal of the plate. The factors that have been shown to be associated with an increased risk of refracture include use of large fragment plates, 4.5 millimeter plates, significant initial fracture comminution, persistent fracture lucency radiographically, and removing the plates too early. If you're going to remove plates from the forearm, it should not be done before a minimum of 18 months have passed, because that's how long it takes for these fractures to remodel. Again, because you're going for anatomical reduction, you're really relying on primary bone healing to occur, and that's how long it takes for the fracture, the bone to recover its optimum stability. So don't use 4.5 millimeter plates, and don't take the plates off before 18 months is the take-home points there. Now, what about synostosis between the radius and the ulna? The risk factors for synostosis, the one that I already mentioned, is trying to fix the radius and the ulna through a single incision. Also, if your surgical treatment is delayed for any reason, if both of the bones are fractured at the same level, if they're high energy, if you have a concomitant closed head injury, if you develop an infection, if the screws are too long and penetrate through the interosseous membrane, or if you have bone grafting into the region of the interosseous membrane. Those can be risk factors. The management of synostosis is to resect it. Of course, the initial management would be to and then you have to do prophylaxis to keep it from reforming. You want to delay your resection until you think that the bone is mature, and that typically requires about a year out from the injury. Really, the results of treatment after synostosis resection are very poor. The only situation where you can obtain some improved functional results are really in the middle third of the forearm. Proximal and distal synostosis really both have very poor prognosis. Distal radius fractures. The last thing we're going to talk about in the upper extremity are the most common of all orthopedic injuries or orthopedic fractures. 50% of them will be intra-articular and involve either the radiocarpal or the radial ulnar joints. They have a bimodal distribution very similar to tibial plateau fractures, where in young patients they're the result of high-energy trauma, whereas in older patients they're quite commonly the result of low-energy falls in osteoporotic bone. There are multiple different classification schemes for distal radius fractures that either classify these on mechanistic or anatomic locations. The Fernandez classification scheme is based on the mechanism of injury. The Frickman classification scheme involves whether there's radiocarpal and or radial ulnar joint involvement. The Maloney classification scheme divides the intra-articular fractures into 4 types. And then, of course, there's the very comprehensive yet cumbersome AO classification system for these fractures. The radiographic evaluation of the distal radius should consist of good PA and lateral views. Remember your normal anatomical features. On the lateral view, the normal volar tilt of the distal radius is 11 degrees. So volar tilt or apex dorsal angulation of the distal radius is 11 degrees. On your PA view, the normal radial height is 12 millimeters. This is the radial height here, which is measured from the alignment between the distal radius and the ulnar articular surfaces to the tip of the radial styloid, and your normal radial inclination would be 23 degrees. And you want to compare that often to the contralateral side as a control. If you have an ulnar styloid fracture, that is denotes a very high energy trauma to the wrist and a greater problems with instability and radial fracture, distal radius fracture displacement. All right, what are the criteria for an acceptable reduction, an acceptable closed reduction of the distal radius? Well, you want to have change in the palmar tilt less than 10 degrees. So, of course, practically what that means is you can accept basically up to neutral alignment on your lateral image. If you have any amount of dorsal tilt or apex volar angulation, that by definition represents greater than a 10-degree change in the palmar tilt, and that would be an indication for more aggressive intervention. If you have radial shortening greater than 2 millimeters, if you have change in the radial inclination greater than 5 degrees, or if you have greater than 2 millimeters of articular step-off. These would all be indications for a more aggressive surgical intervention. Now, determining the stability of the fracture is a key component of the reduction, and the pre-reduction x-rays have been shown to be the best predictor of stability. So if you have a fracture that you know has significant displacement, significant fracture comminution, particularly dorsal comminution, you can predict that those are the ones that are going to be unstable and are probably not going to do well with conservative closed treatment. The instability criteria consist of a widely displaced intra-articular fracture, excessive volar dorsal comminution, significant dorsal angulation greater than 20 degrees, or a patient that has significant osteoporosis, initial fracture displacement or shortening greater than 5 millimeters. Again, dorsal comminution is listed. The articular margin fractures, such as the volar Barton's fracture, those are going to be by definition unstable and require operative intervention. And significant palmarly or volarly displaced and comminuted extra-articular fractures, such as the Smith's fracture. Those are unstable. Treatment options for distal radius fractures, well, cast treatment is certainly tried and true and is appropriate for certain distal radius fractures. You have to follow the patient very closely for displacement in the cast. Again, you should be able to predict the ones that are going to be unstable based on your preoperative radiographs. Of course, cast treatment can cause skin problems. If you have a patient that you're treating closed and the patient loses reduction, repeat close reduction of those injuries is associated with 50% or less satisfactory results. So in other words, if you have a patient that you treat closed, they lose their reduction, their alignment's now unacceptable, that would be an indication for surgical intervention. Percutaneous pinning has been shown to result in excellent anatomic results and functional outcomes when it's used appropriately. It's very useful to maintain the sagittal alignment in unstable extra-articular fractures that are stable on the volar surface. So in other words, fractures where you have dorsal angulation with minimal comminution, you can realign those fractures in the sagittal plane and very nicely stabilize them with one or more percutaneous pins. If you have significant volar or dorsal comminution, however, percutaneous pinning alone is not a good technique as it does not provide adequate stability. The different techniques that have been described for percutaneous pinning are listed there. The one that's really probably of most interest is the Kapanji intrafocal pinning, which can be useful in certain dorsally displaced distal radius fractures to affect reduction in the sagittal plane. External fixation is important adjunct in treatment of distal radius fractures. The one thing that you can remember is that external fixation alone cannot reliably restore the 10-degree palmar tilt that the distal radius normally has. And the problem is that the volar ligaments are stronger and become taut, while the dorsal ligaments are not restored to adequate length. Non-spanning external fixator can give you better control and better fracture reduction, but of course that relies on you having a large intact segment of the distal radius to work with in order to avoid having to span across the wrist. Technical points for external fixation: you want to really limit the duration. Typically 7 to 8 weeks in the external fixator is the maximum amount of time that should be that the patient should wear the frame. And also it's very important to treat the patients postoperatively with aggressive occupational therapy to maintain their digital range of motion. Also, one of the most common technical mistakes made with external fixation distal radius fractures is over-distraction. And you really want to avoid distracting the carpus any greater than several millimeters. And you also want to avoid, placing the wrist in marked volar flexion and ulnar deviation. Those are all factors that have been shown to be associated with a very poor outcome in external fixation of distal radius fractures, particularly with development of reflex sympathetic dystrophy. So you want to maintain the wrist in a neutral position and avoid over-distraction. Those are the key points. If you use external fixation for the appropriate indications and using appropriate techniques, you can get 80 to 90% good to excellent results. What about complications of external fixation? Again, these can be related to the inadequacy of the reduction itself, problems with pin tracks, of course, and complications related to the fracture pattern. If you fail to adequately restore the palmar tilt or the radiocarpal alignment, in other words, you don't get anatomical reduction, you can expect that the patient's not going to do well. Again, avoid over-distraction. That can lead to skin difficulties, stiffness, RSD. You can get late displacement in patients treated with external fixation. That can be seen particularly in patients that have osteoporotic bone where adequate healing has not occurred. And of course, you can get non-unions. Pin complications are listed there. They can occur both with pin insertion. I would strongly recommend that when you're doing your external fixation of distal radius fractures that you place your forearm, your radial shaft pins under direct visualization. Make an incision, visualize the structures. If you've ever been there, you know that it's almost impossible to avoid penetration of either a musculotendinous unit or, more commonly, the superficial radial nerve if you do not place these pins in under direct visualization. So make an incision, make sure you put the pins in properly. Avoid injury to the superficial radial nerve. You can also get median neuropathy, RSD, decreased motion and grip strength as complications of external fixation. Now, what about ORAF? When is ORAF indicated? Well, it's certainly indicated for significant intra-articular displacement, articular marginal fractures such as the dorsal or volar Barton's fracture, or patients that have highly comminuted intra-articular fracture extension, patients that have significant volar comminution, significant proximal extension into the metadiaphyseal junction. Those are probably going to require plate fixation and not do well with closed treatment techniques. If you have an associated fracture of the distal ulnar shaft, and also in some of these fracture patterns, you may need to consider using ORF in combination with other techniques such as percutaneous pinning and in certain situations external fixation to obtain adequate fracture alignment and fixation. Arthroscopy has been shown to help with certain intra-articular fracture patterns, but I think it's fair to say that its role is not clearly defined and it's not preferred by orthopedic trauma surgeons, I can tell you for sure. Complications in distal radius fractures include neuropathy, anywhere up to 1 to 12%. However, if you have a high-energy fracture, that incidence can be as high as 30%. The most commonly injured nerve is the median nerve, of course. You can also get an ulnar nerve injury with concomitant damage to the distal radial ulnar joint. If you have a nerve injury, you basically need to decompress the medial nerve, do a carpal tunnel release. If the patient has progressive paresthesias or the abnormal neurologic exam does not respond to your closed reduction. If you do a closed reduction, minimize the dorsal tilt or the apex volar angulation, and the patient has persistent neurologic deficit, that would be an indication for acute carpal tunnel release. The carpal tunnel pressure is lowest with the wrist in neutral position, so again, you want to avoid placing the wrist into marked volar flexion because that can actually increase the pressure in the carpal tunnel. And then the association with reflex sympathetic dystrophy is not well understood, but we do know that it does occur with certain distal radius fractures, and then when it does occur, is a dreaded complication. Tendon problems, DRUJ injuries can entrap either the extensor carpi ulnaris or the extensor digiti minimi. Again, if you're unable to, if you have an irreducible DRUJ suspect interposition of the ECU, and that needs to be removed. What about tendon rupture due to attrition? The most commonly injured tendon in that manner is the extensor pollicis longus, of course, crossing around the dorsal of the wrist over Lister's tubercle. If the patient has tenosynovitis, then that would require an early release of the EPL, and then and if you have a rupture of the EPL, then a transfer with the EIP would be indicated. Other complications, radiocarpal arthrosis, 1 to 2%, up to 30% in different reports in the literature. The one thing that we do know is associated with an increased risk of radiocarpal arthrosis is inadequate articular reduction. So articular displacement greater than 1 to 2 millimeters will invariably lead to radiographic arthrosis. And if this occurs in a young adult patient, the vast majority of them, virtually 100% of them, are going to be symptomatic and are going to require some sort of salvage treatment. This, again, stresses the need for an anatomical reduction to reduce the articular surface, particularly in young patients. Malunions and non-unions, if you have an intra-articular malunion, you should consider taking that down greater than 6 weeks out. If you have an extra-articular malunion, then that typically what that is an marked apex volar angulation of the distal radius. That is going to require an opening wedge osteotomy dorsally, stable plate fixation of the distal radius, and bone grafting. You also can consider doing ulnar shortening if you cannot anatomically restore the radial length. Now, the last thing is distal radial ulnar joint injuries. These are typically underappreciated and often ignored. They're perhaps the most common source of pain and limited range of motion and disability following distal radius fractures. And the primary factor in preventing disability related to the DRUJ is to anatomically reduce the distal radius. If the distal radius fracture is anatomically reduced, then the distal radial ulnar joint will likely follow and cause minimal problems. Remember that the DRUJ has both rotation and translation, and there's the triangular fibrocartilage complex that is the primary stabilizer of the DRUJ. So the TFC is very important. Evaluation of the DRUJ clinically consists of assessment of the range of motion and stability, as well as examining the contralateral extremity. Again, on the radiographs, you're looking on the plane films for widening on the AP view, dorsal displacement on the lateral view. CT scan, MRI, and arthrogram can sometimes be useful as well. The ulnar styloid fracture, when present, again, heralds a high-energy trauma to the wrist. You really need to suspect a high incidence of instability, especially with large ulnar styloid fractures. Fractures through the base are often associated with rupture of the triangular fibrocartilage complex and resultant instability of the DRUJ. You can get a painful hypertrophic non-union in the absence of instability. If you have a significantly displaced ulnar styloid fracture through the base, then you should consider ORF for those fractures. If you have a smaller fragment that's painful, you can consider excision, but you have to preserve the ulnar attachment of the triangular fibrocartilage complex. Now, DRUJ disruption can be classically associated with a Galeazzi fracture, as we mentioned, which is a fracture of the radial shaft in association with a DRUJ injury. The radiographic diagnosis can be complicated by gross fracture displacement, and the clinical diagnosis can be made by instability of the DRUJ. The treatment is important to recognize these and treat them acutely, because acute treatment has been shown to be superior to late treatment. Anatomical reduction of the DRUJ, you can cast them in supination for 6 weeks. Again, I would strongly recommend using a pin fixation, percutaneous pinning across the DRUJ with the wrist placed in neutral position, again with cast immobilization. Now, what about ulnar impaction with distal radius fractures? And that occurs when basically you have significant radial shortening. You can get positive ulnar variants, and that leads to altered mechanics in the radiocarpal articulation, as well as lunate chondromalacia. You can get degenerative tears of the triangular fibrocartilage complex, and these would be the treatment options: radial osteotomy, ulnar shortening, debridement, or distal ulnar resection, as you see mentioned there. And this is what it looks like here. The previous slide showed the normal radiocarpal anatomy, and here you have a patient that has an ulnar positive variance, and you see there's significant impingement on the lunate in the distal radius. This is what it looks like arthroscopically. Here's a radiographic representation of, again, distinct ulnar positive variants, flattening of the lunate facet of the distal radius, and chondromalacia. This is what it looks like arthroscopically, and this is the treatment for it, to basically do a shortening of the distal ulna and restore the normal variance of the distal ulna relative to the radius. You can also do a so-called wafer procedure, which is where you excise this portion of the distal ulna, preserving the ulnar attachments of the triangular fibrocartilage complex. So DRUJ arthrosis, the clinical findings are pain, limited supination, pronation of the forearm, decreased grip strength. The treatment for it would be a resection arthroplasty. That can be either through a matched or a DERA type procedure. Here's a patient that has significant DRUJ arthrosis secondary to malunion of the distal radius fracture, and the patient gets treated, as you see here, with resection of the distal ulna through a DERA type procedure and can be expected to have a reasonable functional result. All right, so that concludes the upper extremity trauma, and the last thing I'm going to do with this section is just go through the top 10 facts that Dick has compiled for you for upper extremity trauma, and be a good thing to review maybe the night before you go into your exam, because these are the things that he has identified will frequently show up on in-training and board examinations. Clavicle fractures, treat them with plate fixation only if the fracture is medially unstable, and this would consist of the type 2 or the distal clavicle fractures where you have significant medial instability, or if you have an open fracture or a fracture where there's significant skin compromise or a concomitant vascular injury. Remember that there's a very high incidence of rotator cuff tear in patients greater than 40 years of age who have a shoulder dislocation. Beware of the posterior shoulder dislocation, the patient with the isolated lesser tuberosity fracture. I think I've driven that point into the ground. The patients will be clinically unable to externally rotate. When evaluating any shoulder trauma, remember that you need an AP, axillary, and a scapular Y view. Treatment of choice for isolated humeral shaft fractures is a functional cast brace closed treatment. There are specific indications that should be followed for operative intervention, which include open fractures, segmental fractures, the polytraumatized patient, the floating elbow, the patient with concomitant vascular injury. Remember that if there is a higher incidence of non-union of humeral shaft fractures treated with ORIF compared to closed treatment if the ORIF procedure is not done properly. So in order to do it properly, you need to use a broad or narrow 4.5 millimeter DCP, get a minimum of 6 cortices above and below the fracture. Remember also that you can consider intramedullary nailing acutely in the polytraumatized patient and allow that extremity to become a weight-bearing extremity. Radial nerve deficit is associated with closed humeral shaft fractures. It's seen quite commonly. In most cases, it should be managed with observation. Do your electrodiagnostic testing at 6 weeks. If you see fasciculations, you can consider observation because that's evidence that the reinnervation is occurring. If you have fibrillation potentials, that's evidence of denervation, and you can consider exploration and repair. Elbow trauma, any option that you will see listed on your questions that recommends immobilization of the adult elbow for greater than 2 weeks is incorrect, and you can probably cross off that one and go on to consider the other options. Elbow dislocations, the medial collateral ligament is torn in all elbow dislocations. Beware of late posterolateral rotatory instability. That can be diagnosed with the pivot shift test, and the treatment for it is to reconstruct the lateral ulnocollateral ligament. 80% good to excellent results reported with that technique. Radial head fractures, do not excise the radial head acutely. If you do excise it, you try to preserve the radial head whenever possible. If it is necessary to excise it, always perform prosthetic replacement using a metallic implant. Galeazzi fractures, treat the radius with ORIF and either immobilize the wrist in supination to maintain reduction of the DRUJ or pin the DRUJ. If the DRUJ is irreducible, suspect interposition of the extensor carpi ulnaris. Montasia fractures, treat those with ORIF of the ulna and close reduction of the radial head. If irreducible, you should suspect that the annular ligament is the culprit, and that will need to be addressed with an open procedure. Remember that Montasia fractures do have a 20% incidence of posterior osseous nerve injury. Pre-reduction films are the best predictor of stability in distal radius fractures. Post-traumatic shortening of the radius can result in ulnar impaction syndrome, and high incidence of TFC tears can be seen with distal radius fractures, and we talked about all those just now. The treatment of choice for an isolated ulnar shaft fracture with appropriate alignment, less than 50% of displacement, less than 10 degrees of angulation, is a functional cast brace. Now, that concludes the upper extremity section. I'm going to just now try to briefly go through the pelvic ring section, and I'm promise I'm just as exhausted as you guys are, so I'll try to go through this relatively quickly. And so we've come sort of full circle. We started with the acetabulum yesterday, and now we've gone through the lower extremity, now the upper extremity injuries, and we're going to end up with pelvic ring injuries. The outline here of this portion of the talk is listed there, and we're going to end with the top 10 facts for pelvic trauma. Remember that as far as the anatomy of the pelvic ring is concerned, the pelvic ring has absolutely zero inherent bony stability. It's formed by the union of the innominate bones with the symphyseal ligaments anteriorly and the posterior, the sacroiliac ligaments posteriorly. So the stability of the pelvic ring is entirely dependent upon these ligamentous structures. There's no intrinsic stability. Remember that the posterior ligaments, the interosseous ligaments, and the posterior sacroiliac ligaments are the strongest ligaments, and those are actually the strongest ligaments in the human body. We're all familiar with the keystone arch and the suspension bridge concept for the alignment and stability of the posterior pelvic ring. Just remember that the pelvic ring posteriorly relies on these multiple concerted ligamentous structures to maintain its appropriate alignment and stability. Now, what about the acute management of pelvic ring trauma? Well, remember that pelvic ring injuries are very common in blunt, high-energy trauma. There's a large spectrum of associated injuries, and the mortality rate, if you look at all patients with significant pelvic ring injuries, can be as high as 15%. Not all of them necessarily die from their pelvic injury itself, but it is an indication of significant high-energy trauma. And if a patient presents with a significant pelvic fracture and they have subsequently died, then hemorrhage is usually the culprit. Survivors with significant pelvic ring injuries will average up to 2 additional injuries, either in the orthopedic injuries or other organ system injuries. Non-survivors will have up to 3 additional injuries. And 60 to 80% of patients with pelvic ring injuries will have some associated extremity trauma. So again, concomitant injuries are really the rule rather than the exception. You can also have injuries, of course, to other organ systems, urogenital injuries in 12 to 20%, lumbosacral plexus injuries in up to 10%, and remember that 20% of these patients will present either on their initial presentation or during their trauma resuscitation with hemodynamic instability. Physical findings can include scrotal or labial swelling or ecchymosis. You can have abnormal positioning of the lower extremities, malrotation of one limb relative to the other, for example, or you can have pain or movement of the pelvis with bimanual exam, grasping the pelvic bimanually in the region of the anterior superior iliac spine and assessing for instability. It's not something that you want, everybody, including the housekeeper, coming in and doing, because it can potentially, displace some clot and cause some bleeding, but it is important for at least one person to do it on the team to assess the stability of the pelvic ring. Physical examination, you want to remember also to examine the perineum, the vagina, the rectum with these injuries to rule out the presence of an occult open injury, because we know that open pelvic fractures are associated with dramatically worse prognosis. And it's very important that those be recognized and the soft tissue component of the injury be managed very aggressively. Also, focused neurologic exam is very important to rule out lumbosacral plexus injury. The radiographic evaluation, the AP X-ray is what you start with. You're looking not only at the pelvic ring, but also at the acetabulum and the proximal femur. Also, inlet and outlet views, which will show. Consider doing dye studies of the urogenital system, either a retrograde urethrogram or a cystogram, and then CT scanning. The radiographic evaluation, this shows the importance of a CT scan here to help you quantitate and classify these posterior injuries. This is an example of an inlet view. What an inlet view shows you is anterior-posterior displacement of the hemipelvis. So that's what you're looking for in this view. Here's an example of a patient that has a significant pelvic ring injury, and you see that you're able to see here the left hemipelvis has significant anterior displacement here, as well as disruption of the iliac wing here posteriorly. This is an example of this same inlet view post-reconstruction showing anatomical reduction of the fracture. The outlet view, what you're looking for is cranial or caudal displacement of one hemipelvis relative to the other. And the ideal outlet view should be taken with the pubic symphysis basically just below the S1 foramens. This is actually a little bit high here. And this is an example of I believe the same patient that Dick showed earlier, where you see that this same left hemipelvis is not only anteriorly displaced, but also also caudally displaced as well. So this is a very unstable pelvic ring injury, and here's the same patient post-reduction with a very nice reduction obtained. Urogenital injuries should be suspected in any patients that have anterior ring injuries, pubic symphysis disruption, or significant pubic rami fractures, bladder ruptures, urethral disruptions can occur. If you see blood at the meatus or on clinical examination, if you have a high-riding prostate, those would be indications for proceeding with a retrograde urethrogram to specifically rule out the presence of a urogenital injury. Open injuries to the pelvic ring, again, are associated with a significantly worse prognosis, greater morbidity and mortality, aggressive IND, antibiotics, fracture stabilization. If the patient has known to have rectal or perineal communication, then you should communicate with your general trauma surgeon and strongly recommend that the patient undergo a diverting colostomy. The classification of pelvic ring injuries is based on a force vector analysis. The Young-Burgess classification from shock trauma classifies them based on anterior-posterior compression, lateral compression, or vertical shear. And then there are certain ones that have a combined mechanism of injury. This is the Young-Burgess classification system here. Again, the lateral compression injuries are from a direct lateral blow to the pelvis, and anterior-posterior compression injury, the classic open book type mechanism, and then your vertical shear injury, which typically occur in falls from a height or motor vehicle collisions, and then there are certain ones that have a combination of several of those. The force vector analysis that Dr. Burgess described really has been shown to be very useful in predicting mortality, blood requirement for these patients, as well as associated injuries. You see that patients that have an anterior-posterior compression injury were shown to have a blood requirement during resuscitation of 28 units. So these are the ones that will have significant intrapelvic bleeding. The Glasgow Coma Scale in those patients is 10. In lateral compression injuries, the blood requirement is much less. So these patients aren't typically acutely bleeding from their pelvic ring injuries. However, notice that the Glasgow Coma Scale in the patients that Burgess reported was very low. And these are the patients that have significant incidence of concomitant closed head injury. So it's a lot of fun actually to be able to be in the trauma bay and look at the AP pelvis injury and diagnose what type of pelvic ring injury the patient has and be able to predict what other organ system injuries the patient has. So with anterior-posterior compression injuries, retroperitoneal hemorrhage occurs. With lateral compression injuries, you can have closed head injuries and intra-abdominal trauma as well. With vertical shear injuries, you also need to suspect intrapelvic bleeding. The acute management issues, you need to manage and control the retroperitoneal hematoma. You treat the open fractures as we described, and also enlist your colleagues, your urologic and general trauma colleagues to manage the urogenital injuries and the rectal injuries. The acute management goals are to limit the blood loss, minimize the sequelae of late sepsis, and stabilize the pelvis for early mobilization. Remember that if mortality is associated with hemodynamic instability, if you have a hemodynamically stable patient with a significant pelvic ring injury, the mortality is very low. On the other hand, if the patient is persistently hypotensive, the mortality goes up dramatically. The sources of blood loss can include intra-abdominal bleeding or intrathoracic bleeding, and those need to be ruled out. The patients need to have either a fast examination, ultrasound study of their abdomen, or a peritoneal lavage. They need to have a chest x-ray to rule out intrathoracic or intra-abdominal source of bleeding. If those sources are ruled out, then you really need to look at the pelvis as the source of ongoing blood loss. And remember that the pelvis is a tremendous potential space in which bleeding can occur. You have multiple, exposed cancellous fracture surfaces that can bleed, as well as significant disruption to the posterior venous plexuses. If you have a high pressure type situation where you have dramatic hemodynamic instability, then you can suspect significant arterial injury. Arterial bleeding can occur, and this is in the order of frequency, most commonly from the superior gluteal artery, also occasionally from the internal pudendal, the obturator, or the lateral sacral. And this is what's seen on an angiogram here. Control of the retroperitoneal bleeding. The sort of tried and true mechanism for doing that in the literature is to external fixation of the pelvis. And basically what you do is to apply some pins into the anterior pelvic ring, reduce the pelvic volume, and thereby that will lead to tamponade of the vessels. And that works very well for patients in which the blood loss is from the posterior venous plexuses. And again, that represents about 80% of the patients with significant bleeding from pelvic fractures. If the patient has ongoing hemodynamic instability after an external fixator has been placed on the pelvis, or after some external technique has been used to reduce an open book pelvic fracture, those are the patients in which you need to consider arterial bleeding, and those patients need to go angiography with diagnostic and therapeutic intervention to control the arterial bleeding. This is a useful flow diagram. I'm not going to go through it in the risk of time here, but you can refer back to that and basically just lists, how you assess the patient, emphasizing the importance of ruling out interthoracic and intra-abdominal bleeding, and then addressing the stabilization protocol for the pelvis. Now, what about the definitive stabilization of pelvic ring injuries? You can use an anterior external fixator. Certainly, that's a good resuscitative measure with 2 to 3 5-millimeter half pins in the anterior aspect of the pelvic ring. You can also consider placing a pin more anteriorly in the region of the anterior inferior iliac spine, which allows you to have a more lower profile external fixation construct. But I think most trauma surgeons do prefer plate fixation as definitive fixation for anterior pelvic ring injuries. You do not need to do an ORF lateral to the pubic tubercle if the posterior pelvic ring is stable. Posterior stabilization of pelvic ring injuries, anterior SI plating can be performed, or posterior tension band type plating. That has been shown to be associated with significant soft tissue complications and prominent hardware. Really, the use of iliosacral screws in the last 5 to 10 years has revolutionized our treatment of posterior pelvic ring injuries, because it can be inserted through a minimally invasive percutaneous technique, is good for both sacral fractures and SI joint dislocations. The one caveat to that is you really need to be aware of potential iatrogenic injury to the L5 nerve root because of its location just anterior to the sacral ala. So that's shown here diagrammatically. This is the safe zone for placement of a iliosacral screw into the S1 vertebral body. You want to visualize that on your lateral fluoroscopic image of the sacrum, and then this is the correct orientation. And then I think this slide shows the inappropriate placement of a screw which penetrates through the anterior aspect of the sacral ala and could potentially damage the L5 nerve root. Pelvic ring injuries, outcomes, pain is the most common reason for a poor outcome, and poor outcomes have been associated with, most commonly, with incongruity of the sacroiliac joint. That's one take-home point to definitely remember. The sacroiliac joint must be anatomically reduced in patients with posterior pelvic ring injuries. If not, that is going to predictably lead to a poor outcome. If you have a high degree of initial displacement, malunions greater than 1 centimeter, leg length discrepancies greater than 2 centimeters, non-unions, or concomitant neurologic or urogenital injuries, those are also associated with poor prognosis. Deep venous thrombosis always needs to be considered in patients with pelvic ring trauma. It occurs in up to 60% of patients. It can manifest as either deep venous thrombosis or occasionally fatal PE. Prophylaxis is essentially important in these patients, either with mechanical compression and low molecular weight heparin. So you want to use actually mechanical and pharmacologic DV prophylaxis of these patients. Certain patients in which, for example, low molecular weight heparin may be contraindicated, such as a patient with a severe closed head injury, then that might be a patient that you would consider doing a venocable filter. Sacral fractures, the last thing to talk about, reported in up to 70 to 85% of pelvic ring injuries. They can be missed in 50% of patients that present with neurologic injury, and in up to 75% of patients that present with neurologically intact. Lower sacral root function is responsible for anal sphincter tone, voluntary contracture, the bulbocavernosus reflex, and perianal sensation. If these lower sacral roots are disrupted, these are the types of long-term deficits you can expect. Imaging of the sacrum, an AP view will in the 45-degree plane is helpful, as well as inlet and outlet views, as we mentioned, and then CT scan is really the study of choice. The Denis classification scheme for sacral fractures divides them into zones. Zone 1 are essentially your alar fractures that's lateral to the neural foramina. These typically are minimally displaced in APC and lateral compression injuries. In vertical shear fractures, however, these can be significantly displaced and will require treatment. Neurologic injury is relatively rare in these fractures and occurs in about 6%, and when it occurs, it's the L5 nerve root. The Zone 2 fractures are the transforaminal sacral fractures, and those are significant in that they have a significantly higher incidence of neurologic deficit, either to the L5 or the first 2 sacral nerve roots. 97% of those can be undiagnosed in zones 1 or 2. Then the Zone 3 injuries are essentially injuries that are basically spinal canal problems. They're medial to the neural foramina. The majority of those will have neurologic deficit, and they can cause caudal injury with bowel, bladder, and sexual dysfunction. Transverse fractures of the sacrum occur in the upper sacral segments or in the lower sacral segments. If they're in the upper portion of the sacrum, again, you have a higher incidence of bladder dysfunction, and the H fractures are particularly unstable and require surgical stabilization, typically stabilizing the sacrum to the lower lumbar spine. Neurologic injury in sacral fractures the outcome has been shown to be improved with decompression. You can do it indirectly through reduction and stabilization of the sacral fracture, or you can do it on direct visualization through laminotomy and ventral foraminotomy. Postmortem studies have shown a high incidence of root avulsion with transforaminal vertical shear and transverse type fracture patterns of the sacrum. The treatment of zone 1 injuries, if it's stable and non-displaced, you treat them non-operatively with protected weight bearing. If it's minimally displaced, you can consider stabilization of the anterior ring if the symphysis is disrupted or you have a significant ramus fracture. The vertically unstable fractures should be treated with both anterior and posterior stabilization of the pelvic ring. Zone 2 treatment, where the foramina are patent, you can treat those non-operatively with protected weight bearing and frequent follow-up films, and you can expect some neurologic recovery in those patients. Again, that's where the foramina are patent and you don't suspect that there's compression of the nerve roots. If the fractures are unstable or you have foraminal compromise, those patients need direct or indirect decompression with anterior and posterior stabilization. Finally, zone 3 fractures that are stable and neurologically intact, non-operative treatment can be dictated by the associated fracture of the anterior pelvic ring. If they have neurologic deficit, they need decompression, anterior and posterior stabilization. Unilateral sacral nerve root preservation can be adequate for bowel and bladder control. So you at least want to have one of the nerve roots intact. Transverse fractures that are displaced need to be treated with lateral mass plates, again, commonly with fixation into the lower lumbar spine. So sacral fractures, anterior injuries can be managed with an anterior external fixture and ORF. Then the posterior injuries can be treated with iliosacral screws. Again, beware the L5 nerve root. You can also use sacral bars or tension band plating. The problem with both of these techniques is that they do have significant potential for soft tissue compromise, and you can get overcompression, particularly of the lumbosacral nerve roots. Now, finish up with the top 10 facts for pelvic trauma, and sorry I'm running about 5 minutes behind, but remember that the posterior ligamentous structures are the strongest structures, they're the strongest structures in the body and are responsible for the posterior stability of the pelvic ring. Urogenital injuries, when you have a severely displaced anterior ring fracture, wide open, pubic symphysis diastasis, a high-riding prostatic clinical exam, blood at the urethral meatus, those patients need to have a retrograde urethrogram. If they have persistent hematuria and the RUG is negative, then they need to have a cystogram to rule out a bladder rupture. External fixation, now Dick mentioned this, but this is a little bit controversial. He says that external fixation should precede arteriogram in the hemodynamically unstable patient with an unstable pelvic fracture. I would modify that a little bit and to say that some sort of external immobilization of the pelvic ring. And I think most commonly what is done now, and I think what is probably appearing on standardized tests, is that you need to, if the patient is unstable, you've done adequate fluid resuscitation of the patient has a pelvic ring injury, they're unstable, they're hemodynamically unstable, the next treatment of choice would be due to some external immobilization of the pelvic ring. You can tie a sheet around the pelvis, you can place a bean bag, something, and if that technique does not result in hemodynamic stability, then the patient should go to arteriogram before undergoing external fixation of the pelvic ring. Again, because we're now understanding that more instability is caused than we previously recognized by acute arterial bleeding, and performing an arterial embolization can be a life-saving procedure. So I would recommend that you kind of disregard this fact that he's mentioned, and really I do not think that in most cases external fixation should be performed before arteriography. And I can tell you for sure that's the way that the American College of Surgeons is training trauma surgeons today. The sources of arterial bleeding in descending order of frequency in the pelvic ring trauma, the superior gluteal artery is most common, followed by the internal pudendal, the obturator, and the lateral sacral. Diagnostic peritoneal lavage or fast ultrasound examination should be performed to rule out intra-abdominal source of bleeding. If you're going to do a DPL, encourage your trauma surgeons to do it through a supraumbilical incision to avoid compromising your approaches for treatment of the pelvic ring. Open injuries into the rectum and perineum do require diverting colostomy. That's an important point to remember. And poor outcome in pelvic ring injuries is related most commonly to incongruity of the sacroiliac joint. So it's very important to obtain an anatomical reduction of the SI joint. Also, severe initial displacement, residual displacement less than 1 centimeter, and the other criteria that are mentioned there. Zone 3 sacral fractures these are the basically spinal canal disruptions, have the highest incidence of neurologic injury. They can have caudal neurologic dysfunction with bowel, bladder, and sexual injuries, sexual dysfunction. And you see that as you go from a zone 1 to a zone 3 injury, there's a dramatically increased risk of neurologic dysfunction. Zone 1 injuries are the most common location of sacral fractures, up to 50%. Zone 2s and 3s are less frequent. The L5 nerve root is the structure most at risk with placement of an iliosacral screw. And again, that's the anterior location of the L5 nerve root, just anterior to the sacral ala. SI joint dislocations, again, require anatomical reduction and stabilization. And pubic rami fractures lateral to the pubic tubercle do not require fixation if the posterior pelvic ring is stable or if some stabilization is performed of it. So you don't really worry about these more lateral rami fractures. That's it. Thank you very much. I really appreciate your attention.